and Dr. Ved Prakash Mishra will also join in some time. There is some technical issues. I'd like to welcome our past National President, Dr. Ravi Wankhedkar, a very dynamic personality. So also our MMC President, Dr. Shivkumar Uttara sir. So also our President of Maharashtra State, Dr. Ram Krishna Londe sir has also joined. Organizing Chairperson, Dr. Ravindra Kote sir. We have designed this program. I request President IMA Shirdi, Dr. Vakkave Pritam, to say a few words and welcome all of this gathering and this conference. May I request Dr. Pritam? Dr. Pritam, have you joined?
No, Dr. Pritam is not there.
Okay. So I'll like to request Dr. Ravindra Kote, organizing chairman for this conference, to say a few words and we can start. Thank you, sir, and thank you all.
Everyone, Dr. Ved Prakash Mishra, Dr. Eric De Souza sir, Dr. Ravi Wankhedkar, Dr. Shivkumar Uttara sir, Dr. Ramakrishna Londe sir, Dr. Shailaja madam, Dr. Sushma Sharma madam, and all the members. Bioethics conference is arranged by International Chair of Bioethics, IMA Maharashtra State, Medical Students Network, Junior Doctors Network, and it is hosted by IMA Shirdi branch. Hello? Hello?
Yes, sir.
Yes, sir,
You are audible.
There's some
How was it,
fire
sir?
coming in the way. Okay. So this is a consecutive 8th year of IMA Shirdi branch to organize state, national or international conference. And today we are having excellent faculties like Eric De Souza sir, Ravi Wankhedkar sir, Shivkumar Uttara sir, Sushma Swaraj madam, Sushma Sharma madam, Shailaja Mane madam, Motilal Taide. And today's session will be chaired by Dr. Anil Pachnekar sir, Dr. Ashok Tambe sir, Dr. Y.S. Deshpande sir, and this is going to be a very memorable event. 2 days back, we are arranged one Bioethics conference, and it was appreciated very well. And I think this is the second conference on bioethics, which will be again highly successful. I am thankful to the MS Nigerian coordinators for joining this event. There's best wishes to this bioethics conference. Thank you very much.
Thank you, sir.
Rajan, please continue.
Yeah. So we'll start the webinar. Today's chairperson, I think they have not joined. But Dr. Aline Pachnekar is a past national vice president now of headquarters, being our chairperson. Co-chairperson is Dr. Y.S. Deshpande, Dr. Ashok Tambe. I think there is some technical issue they can join, but they will join soon. Now I'd like to request Dr. Eric De Souza, who is the head of training Indian program, and his today's topic is the new normal remaining COVID positive. So I request sir. Over to Dr. Derek De Souza, sir.
Thank you, sir, for that kind introduction. And I will just share my screen. I hope that is visible to everyone.
Okay. Okay, sir.
Yes, yes, sir.
Thank you so much. And it's wonderful to be here. I thank the organizers, IMA Shirdi, our own management of Maimar Medical College, who is the educational partner for this event. And of course, all my distinguished colleagues and co-speakers at this occasion. It's really wonderful and an honor to be here. I know we are having dark clouds, not just you can see it on the screen, but those of you who are in Pune right now, luckily, there's been a little bit of cloudy weather and we just had a little bit of shower. So I think that's a good sign. It's a good omen and showers of blessing on this memorable occasion. So we have been having these dark clouds, in fact, almost for a year now. And despite all of that, I say some words which possibly would be a little confusing if I wish you all to be staying COVID positive. But let's see how true is this as we go ahead. And I think this is one of the most famous pictures, not just for now, but I think for a long, long time to come, people are going to know what this tiny little virus is all about. And this is possibly one of the most dreaded feelings that somebody could get today, where you would be labeled as COVID positive, and not just among the health workers, but even others as well. The minute you hear that you are COVID positive, it brings a lot of fear and anxiety. We know that there is a rising number of cases. It's not very good news to hear that Maharashtra is in the lead, and Pune and Mumbai especially are having a huge number of cases even as we speak. So despite all this bad news all around, I urge you all to be positive. And not only that, is there a reason for us to stay positive? Because I think mentally, physically, and emotionally, this is the only way that we can face this very tremendous challenge that is put forward to us. And hopefully, in the immediate future, Maharashtra, Pune, and Mumbai would be taking the lead in announcing that we have defeated and we have addressed this challenge in a very realistic way. So what are some of the positives that we can take away of this pandemic? One, of course, would be in healthcare, families and society, education and training, environment, and the economy. So let's look at healthcare. One of the biggest advantages that we can have is that all our healthcare professionals have realized the importance of going back to the basics, things that we had taken for granted. In many, many ways, we have been able to maximize the use of technology, especially in telehealth. It's important to understand what exactly is a cause and effect and benefit harm evaluation. It's also an important reminder that we should not just follow any data, even if it is published in a reputed journal or on a reputed site. And getting back to the importance of understanding self-reliance and self-sufficiency. So since December 2019, fortunately, the pathogenicity of SARS-CoV-2, that is the COVID-19 virus, has been identified and verified. Randomized trials for various treatments are also in various stages of completion. We've also been able to utilize artificial intelligence to distinguish COVID-19 from other pulmonary infections using radiographic studies, which is a big step forward. Even our industries have been transformed. And of course, all over the country, vaccination drives are in full swing. So these are indeed some positives that we can be grateful for. Let's look at some of the basics that we had forgotten. This very understanding or the importance of hand washing and hand washing in the right way at the right time. And even in the immediate aftermath, a lot of the hospital-acquired infections had dropped just for this one reason, that something we had taken for granted, simple thing as hand hygiene, had come back and everybody was following this practice. Again, simple things like using face masks, avoiding touching yourself or any other surfaces, regularly washing your hands, like I said, maintaining physical distance, clean and disinfect all the areas in the clinic or the operatory wherever you are functional, and of course, staying at home and not going out until it was absolutely necessary. Let's look at the use of technology. This, of course, is the government health site, and of course, a lot of hospitals and private clinics as well decided and found that this was indeed a maximizer and a way to still attend to their patients in quite large numbers, avoid them coming to the hospital, avoid them being exposed to unnecessary infection, and still able to provide a decent amount of treatment, especially in cases of follow-up, or where people just had questions, or where they were worried whether they were suffering or whether they needed to visit the hospital. All this was possible on a teleconsult. Again, a lot of the apps have come up into the market, various smart devices that we are possible to have with us. We were able to integrate all these and extend the reach of our healthcare coverage. Again, importance to understand what was exactly cause and effect, what is benefit and harm, and also not to just follow some data because it was published. All over the world, we know one of the reactions by the healthcare industry was a sudden rise in the number of publications that were there. You can see on your screen the relationship between the total number of publications and the publications which were there on COVID-19. But this is something that we always have to remember, especially for all the students who are there and even our faculty. Just something, if it is published, does not mean it is trustworthy. We can see the large number of removed and cancelled studies that are there on this slide. And of course, we know how much within the past 1 year, even the treatment protocols have been redefined as well. So what is important? We need to review the literature. Let us evaluate it among our peers. Let us evaluate and see, does it apply to the conditions that we are in? Does it apply to my particular patient? Assess the case properly, discuss it with the expert, discuss it with your peers, and only then decide to apply it or what exactly the treatment protocol you wish to go ahead. Again, the importance to understand what is the reason for self-reliance and self-sufficiency. In many ways, We are grateful to our scientists, researchers, healthcare workers, even factories. And a lot of companies we know in the last year and even till now have taken on an additional burden of either producing oxygen, producing sanitizer, producing ventilators in order to help the national effort. And we're very grateful to them for helping us in joining this challenge. Very proud to show this slide. This is the team of ICER in Pune who have developed this low-cost ventilator. And if we have more innovations like this, I'm sure the future will continue to be bright despite all the challenges. Again, India has been in the headlines for good reasons as far as the vaccine supply is considered. And again, Pune can feel very proud to be at the head of this. So all those who are involved, we are very grateful to them. And of course, when you look at even the developed countries who have actually started saving the vaccines far beyond what they would need for their immediate population, I think India is showing leadership. India is showing solidarity with the world in sharing the vaccines. And again, I'm sure that we will be able to ramp up the supply and ensure that none of our population is neglected when they need it. So again, some of the vaccines that are there in the pipeline, you can see it's good to see such a large number which is there on the screen right now. I know they are in various stages of production, but just the fact that we have so many alternatives itself is a very positive feeling. And again, we as healthcare professionals need to keep an open mind, be able to transmit such information to the people that we have so that we can look at the future. Again, this is a clinical trial that has been carried out in the UK, and it's shown very promising results with nitric oxide nasal spray. And we hope and pray that this, in fact, is the treatment that we are looking for. Of course, at the same time, this is an article just published yesterday on the WHO site, and it asks a very important question of do we need to update our tools in assessing the COVID-19 vaccine performance to work against the novel variants. So this is an important part. I think we as healthcare professionals can help in order to look at the performance of the vaccine, to have a very open mind and to see in what way we can go ahead. Of course, our families and societies, despite all the challenges of the lockdown, in many ways, I feel the relationships were renewed. Families were forced to be together. Everyone started experimenting in the kitchen, whether it was cooking or baking or even online work or online family events kept people together. And we also realized the value of spending time with people that matter to us, because the number of friends and family that were lost, of course, is very sad. And all of a sudden, it made us realize that we should stop taking each other for granted. Traditional games such as these, it's very heartening to see the children leave their mobile phones, leave their online games, and come back and learn with the older generation. So a lot of things that we would have otherwise lost, I think this is a huge gainer, getting the families together, getting back smiles on each other's face. Of course, our youngsters and even us who are still middle-aged, may I say, learned various techniques of keeping together. Education and training itself, it was a big challenge, I remember, even in our college, when all of a sudden we were told to shift to online classes, and we were literally scrambling for ways and means of trying to understand. In fact, I remember the first time I took a lecture on Zoom, and there was one student of mine who decided to experiment by drawing and scribbling on the screen. Maybe he was scrolling on something. And it was so disturbing and so distracting for me. And I just didn't know what to do. But I think from there, we've progressed quite a bit. We've learned of the various advantages. We've learned how to use these digital platforms. So that itself is a great takeaway. And of course, that reminds us that we need to adopt, adapt, and even encourage newer training paradigms. So it's very difficult, I know, for faculty when they say, we can't carry out our clinical training. What is going to happen to medical training? But if we give our mind to it, if we think of ways and means by which we can continue our training, I'm sure we will be able to find something in the future as well. So all of a sudden, these various platforms that were there became absolutely household names, whether it was for our children or whether it was to connect with our students. We had all these platforms come up to us and we were able to use them quite effectively. So whether it was students who became very familiar looking at their teacher, and of course we have so many anecdotes of how the students would try to fool their teachers or somehow avoid putting their camera on so that they could continue to attend the classes in the way that they felt comfortable. But despite all of that, the teachers were able to overcome these challenges. So that's something really nice. Again, the most common words that we still keep asking, am I audible? Can you see my screen? And of course, please mute yourselves when there is too much. So this is the new language that we are speaking. And even as we are talking here all across the country on this digital platform, it shows us that there's a new way ahead and we have not given up. Whether it is weddings that happened on Zoom, or family reunions or reunions of friends all over the world, we suddenly found this new normal and we've adapted so well that we actually find it more advantageous. And even this conference itself, we've seen with minimal transfer of people from one place to the other. Despite today being a lockdown in Pune and most of Maharashtra, we were still able to all meet together on this digital platform. The environment, we know how beautifully the minute the human element had been reduced, we had reduced effluents from factories because they were closed. The air became cleaner. And in fact, all the pictures that you see here on screen, they may look from some foreign country, but we are very proud to remind you that yes, they are from India itself. Again, we had the wildlife, which came back. This is a very small video, but it's very beautiful. So I'll play it for you. And it reminds us that if we just open our eyes and change our lifestyle a little bit, we can return to a much better time. So let's keep these few ideas in mind. Let us remember that we need to survive keeping nature and keeping these other creatures in mind as well. The advantages, even a river like Yamuna, where crores and crores were spent so many years, but just with the lockdown, this river had improved to a considerable extent, and even the quality of air in most of our metros was improved. Even for our economy, if we remember the state that we were in 18 and 19, where it was everything was global, people were looking at things online, and we had actually forgotten our small local grocer shop. We had forgotten the people who were producing local products. And when we were hit by the lockdown, it's that small grocery shop who kept his shop open, continued to send the items that we wanted, sometimes even home delivery at a huge risk to their own. So all these small businesses, these local traders, and they reminded us that we need to, a very minimalistic living and lifestyle is possible. And of course, even for the offices, we had this work from home model, which actually succeeded. Despite all that, we can see that even the prediction here for 2021 still continues to be good, and we hope that the economy will revive sooner or later. Again, for all the reasons, whether China was actually responsible or not responsible, not going into that debate, but it gave us a chance to understand that we need to be self-reliant and we need to look at made in India, rather use every product which was made in China. So what are the areas that we can improve on? Yes, the first point, and let us keep it at the forefront, the importance of our own as well as our colleagues' safety. We've lost too many colleagues, not really always a fault of theirs, but some of them literally went out of their way to deal with their patients, to do their duties during the pandemic. So let's keep ourselves safe. Still, sad to say, there are a lot of unethical practices by our own profession. So before we point fingers at others, let us try and see that we follow all the rules and regulations that we need to follow, avoid getting into habits and into, in whatever way, if we come to know that there is an unethical practice or something going wrong, let us stand up and protest that, because it's just a few people who are giving the profession a bad name. We need to discipline ourselves. We need to open our mouth and tell people to wear their masks and wash their hands. Because as healthcare professionals, that is our duty. Sometimes we feel a little bit shy. Sometimes we feel a little bit hesitant, but this is our duty now. And let's be united to face the challenges, to share knowledge and technology, and of course, respect each other's profession, because that is the only way forward. So what are the lessons for the futures? Let's use the strong foundations that we have in our country. Our healthcare profession is thriving in a way that we can change the future. We need to look at what are strengths, weaknesses, what are the opportunities and threats, and decide what is going to be the roadmap for the way ahead. We are already prepared, I can say now, for this challenge, but we need to take it forward. Again, we had gone into complacency probably around the new year, thinking that, okay, 2020 is gone, the cases had significantly reduced, but they've come back. So we cannot be complacent anymore. All the good habits that we had learned, we need to relearn them and continue. Self-reliance and self-sufficiency help industry, help us, and look around and see in what way we can continue to give the best to our patients. Let's think out of the box, not just in the healthcare profession, but as educational professionals also, and look for innovation in every which way that we can. So as we come to the end, these of course are the principles that we should allow to surround us, keeping healthcare at the center, whether it's non-maleficence, integrity of the patient, respect for the patient, following rules and regulations, dignity, keeping confidentiality, and all the other principles that we had forgotten to some extent. Let us use this as a beautiful rainbow of color to continue to allow healthcare to excel. So as we end, I urge you, dear friends, let us not forget the hard lessons that we have learned. Let us not make the sacrifice that so many professionals have made, many of them at the cost of their lives, but let us carry this forward. So once again, I urge you to stay positive during this pandemic, stay safe with yourself and with your families and with your patients. Thank you for a patient hearing. And if there are any questions or comments, I will take it at this time or maybe later at the end. Thank you.
Thank you very much, sir. I would say a very pleasant and excellent presentation. You talked about adopt, adapt, encourage, and and new horizons are there for us. Talked of SWOT analysis, strong foundation, self-sufficiency, think out of box, and the innovation. We are, I would say, really proud to have you on this platform to encourage us, inspire us. Thank you very much, sir. And about the question answers, we can take later on, short of time. And first thing, I'd like to welcome Dr. Ved Prakash Mishra, sir. Welcome, sir. And I would request Dr. Ved Prakash Mishra, sir, to address. Sir is Vice Chancellor of Datta Meghe University, and Chairperson of Indian side of Bioethics programs, and is a well-known personality, very good speaker. I've heard him a lot of times and still feel to have a lot of inspiration and gather some knowledge from him. So I request Dr. Ved Prakash Mishra, sir, to address us. Thank you, sir. Please take over.
Thank you very much, sir, for your kind, good words. At the outset, I would like to record my unconditional apologies for joining you late because of an earlier preoccupation which mandated me to be with you a bit later. I deem it my pleasure and more so my duty to record my sincere sense of appreciation for a very notable initiative that has been taken by IMA Shirdi branch in collaboration with MSN, JDN and MIMER Medical College for organizing this Sai Ethicon, which is really heralding into a gamut of expertise depiction by very learned speakers that include my esteemed friend, Dr. Eric De Souza, my learned brother, Dr. Ravi Wankhedkar, our chairman of the Maharashtra Medical Council, Dr. Shivkumar Utture, Dr. Shailaja Mane, Dr. Taide, so on and so forth. A real learned galaxy which will be taking up the various themes and bringing out the various facets and dimensions. I bring out to all the organizers pleasantries from Professor Russell De Souza and the International Bioethics Chair Haifa for this notable initiative, which is a logical extension of the pursuit which has been undertaken by the said agency. Ladies and gentlemen, I had the fortune of listening to Dr. Derek. He has very rightly brought in that the entire world is undergoing a trauma which perhaps nobody had envisioned in any manner, least any imagination of any type. Are we to be bogged down is a $1 million question. But then resilience that has been the hallmark of men and mankind has always stood the testimony of it rising even from the grave. The mankind has been the sphinx of all times. And therefore the real worth is that even in this entire threat, there are challenges and there are embedded opportunities. The contemplation which we are wanting to be taking up for all of us as medical professionals is, pandemic brings out a plethora of dilemma, those which are required to be tackled, those which are required to be addressed, those which are required to be balanced. Be it you and me as individuals, be it you and me as a complete group of professionals, be it you and me as a community, and be it you and me as a whole society. There are concerns, there are challenges, there are various confronting situations which are raising their head, and we are required to be offering pragmatic solutions so that the things are tided over. These dilemmas, they have to be worked up, ensuring in a modern manner that the core principles of ethicality and morality, which have been the hallmark of the entire dispensation, they are upheld. The situation is tough. The entire gamut is difficult, but then it is the hallmark when I'm tempted to say in my opening address to only bring out one core line fact, which perhaps gives us all a ray of hope, and that is, quote, when the going is tough, tough get going, unquote. This is a test of time, ladies and gentlemen. I'm so very happy to record our appreciation the learned martyrs who rendered their lives in espousing this cause. We salute their memories. We salute their sacrifices, be it our professional colleagues, all the frontline workers which have risen to the occasion, risking their own lives and have stood the test of time and have emerged as valiant warriors. They are the emulable examples. They are the exemplary dispensations which are inspiring and which have given us a path for us to follow. It is in that context, ladies and gentlemen, the challenges which are there, they have to be mitigated. They have to be answered. Let us avail the opportunities which are embedded in that. Very rightly put in across. Various challenges in terms of the care, in terms of the cure, in terms of education, in terms of social ethos, in terms of economy, in terms of elegant placement in every walk of life, which perhaps would have come to a standstill. It has been given a fillip. It has been given a way forward. There have been various dimensions which have been in a position to generate a kaleidoscope of its own type. And that is exactly what human ingenuity and human innovation is. And therefore, ladies and gentlemen, this initiative which has been undertaken, wherein all the learned luminaries are expected to be dispensing their thematic depictions by virtue of the authority that they command at their disposal, would be again a beautiful kaleidoscope, which should not only be bringing out the challenges that confront us, but also the roadmap which has been carved so far, and the roadmap which can be put across in terms of an actionable blueprint for really making ultimately the face of humanism and humanity glitter as it has always been. Human race has emerged from all ordeals. If you take the entire historicity of human race, name a situation which was not difficult to confront, but it has been confronted, it has been mitigated, and the human race from that advent has always emerged a step ahead and has grown to its glory. This also shall not be any exception. If the entire human history is a testimony, even we will be in a position to surmount this challenge and make the travesty of human history grow and glow in its path, which has been its past treatise. But then it is imperative that when we are confronting a situation like this, there have to be glittering dimensions, igniting in character, which will ultimately generate the required illumination. I take this initiative of the IMA Shirdi branch in collaboration with MIMER Medical College, in collaboration with JDN MSN, and in presence of all the learned luminaries putting across in terms of deliberation, the ticket from me. This is once again an important igniting point which will bring out the desired illumination which is mandated in the interest of men, mankind, humanity, and humanism as a whole. Therefore, I, in my humble capacity as the national head of Bioethics, Academic Bioethics program of Haifa, on behalf of Dr. Russell and all concerned, record my appreciation and thankfulness to the organizers and also all the learned luminaries who will be dwelling their expertise in various dimensions in this Ethicon. Recording my sense of appreciation and gratitude, even at this juncture, I deem it to declare that I feel honored to be a part of this particular learned gathering on this particular occasion. I would definitely love that we will be in a position to script what is desired so that at the end of the day, the required dimensions which are needed to be opened up in the humanistic interest, they will be opened and we shall be the cause of it. Let us dispense our roles and responsibilities in the desired and elegant manner so that the posterity, whenever it will be in a position to be recording its historicity, it will be in a position to record for us to the extent that yes, they came, they saw and they also conquered as their ancestors. Thank you very much for the patient listening, and thank you very much for giving me this opportunity of putting these ventilated thoughts of mine across all of you. Thank you very much, and God bless you all.
Thank you very much, sir, for your kind words. We salute your dedication and devotion for medical fraternity. You inspire us a lot. So thank you for your blessings. And with your kind permission, we can go ahead. Okay, sir. Thanks a lot.
Please.
May I request now our next speaker, Dr. Ravi Wankhedkar, sir, who needs no introduction as his world well-known personality. Sir has been a national president, past president, and a very dynamic leader also, and inspire all of the medical fraternity. Might be any of strike also, the mexopathy issue also, a lot of things. Sir is treasurer of World Medical Association, now president of SARC Medical Association. So I request Dr. Ravi Wankhedkar to take over. Please, sir.
Thank you, Dr. Rajan, for the kind words. Our friend, philosopher, guide, and whom I always called as the fifth Veda, Veda of modern medical education, respected Honorable Dr. Ved Prakash Mishra, sir, the President of IMA Maharashtra State, Dr. Ram Krishna Londe, sir, my fellow learned panelist, my dear friend and my colleague who has dedicated his entire career and life for the promotion of bioethics, Colonel Professor Dr. Eric De Souza, my brother and the guardian and custodian of ethicality in the state of Maharashtra, the chairperson of Maharashtra Medical Council, Dr. Shiv Kumar Utture, my learned friend who is very, very active in the bioethics program, Dr. Shailaja, Dr. Shushma, Dr. Taide, the organizer of this event, Dr. Ram Krishna, Dr. Ravindra Kute, my another dear friend who is helping us out in the testing period for last 1 year through DG Shield, Dr. Rajan Sancheti, the president of IMA Shirdi, my younger brother Pritam Pyare, whom I fondly called, the secretary Dr. Swadhin, the honorable chairpersons and all respected colleagues and friends. Indeed, it is in fitment of things that the Shirdi branch has arranged a conference on ethics, the Sai Ethicon, because one of the two principles of Sai Baba are Shraddha and Saburi, that is patience and to have faith. I think these two principles are very, very important in maintaining the trust between the doctor and patient, to have faith and to have patience. So I congratulate the IMA Shirdi branch along with Dr. Kute for arranging a very apt conference under the banner of IMA Shirdi branch. I also thank the Mymar Medical College, the IMA MSN and JDN unit for helping us in arranging this conference. In brief, let us today discuss the ethics in surgery. Working as a professor of surgery and in the field of surgery for last 30-35 years, and working in bioethics program under the able guidance of Professor Karmi and Professor Russell. Let me share what little insight I have got into this particular topic. First, we will discuss what is ethics in general in medicine, and thereafter we will discuss specific topics related to ethics in surgical practice. Firstly, let us try to understand that what is the primary reason of discussing ethics with clinicians. It is basically as a clinician to enhance their ability for the patient care and families in clinical settings, and also more importantly in today's scenario for the safety of doctors. If you'll go through the history of ethics, you will find that ethics is not something new. Entire medieval world, we had various code of ethics, right? Maybe in the Chinese history of medicine, in the Egyptian history, and in our own Siddha or Ayurveda methods, which was later on adopted by the world. And now what we see right from Hippocratic Oath today, the World Medical Association's Declaration of Geneva is what we follow. Basically, ethics is a group of moral principles or set of values that define or direct us to the right choice. It is a dialogue between scientists and humanists to preserve humanity from self-destruction. So ethics basically forms the core of the law, the values, fairness, and the morals all together. It, as a clinician, we all observe that we all the time face medical and ethical dilemmas, whether whatever we are doing is right or wrong, but it depends. This is the greatest dilemma of what to do, and here study of ethics and bioethics definitely is of great help. Because as you will see, between the black and white area, there is a huge gray area, especially in the field of clinical medicine. Certainly, definitely we know the black area is that it is unethical and illegal. And the white area is ethical and legal. But in between the gray area, there are many instances where you find that it is ethical but illegal. Or it is unethical but it is legal. So to try to navigate through this difficult situation, the role of ethics comes. Knowledge of how to use knowledge. And why ethics is important? Because the fundamental values of human life, dignity of the underprivileged, the justice in healthcare, bodily integrity are at value. And that is the need of ethics. Because unlike pure sciences, medicine is a combination of science and art. And when we add philosophy to it, it becomes ethics. Because we all have observed that from healers, we became doctors. And from doctors, now we are turning into medical technicians, where we are not treating the patient as whole, which was envisaged or embodied in our medical education. We are treating only the disease. Thereafter, now a time is come where we are treating only the investigations and not the disease. Hence, we need to reverse this. And to reverse this, the knowledge of ethics is very, very important. And today we have Dr. Ved Prakash Mishra sir, who started this process by changing the medical curriculum by adding the various Ethicon module in the medical curriculum so as to help this journey from medical technicians to holistic health in the form of doctors becoming healers. And as I said, it is also important for the safety of doctors. Not only if you are ethical and if you are able to solve your ethical dilemmas within the accepted principles, the violence decreases, the medico-legal cases decreases. Hence, if you will find that there is always a dilemma between evidence-based medicine and clinical-based medicine. Of late, we are into evidence-based medicine. But in good old days, it was clinical-based medicine. And we have to strike a balance. And this cornerstone in building a good doctor-patient relationship is ethics, and nothing but ethics. Now, if you will see the practice of ethics, the core of surgical ethics is the surgeon-patient relationship and the surgeon's responsibility to advance and protect the well-being of patient. It emerged to examine the problems specific to surgeons. And these problems, friends, are closely linked to the development of science and technology. The surgical ethics have to be distinguished from other medical fields because surgery has its unique characteristics and goals. Ethics lie at the core of professionalism because a proficient surgeon is considered to be not only competent to perform the art and science of surgery as traditional understood, but also to be ethical at the core. So the practice of surgery is based on three basic principles, friends. One, is the technical capabilities of the surgeon. Second is their knowledge. And the most important part, which forms the backbone of the ethicality, is the capacity of judgment, or what we call as phronesis. Surgeons very often face situations that call into question moral choices, and they face a number of ethical difficulties in their daily practice. With innovation increasing and the operations becoming more and more complex, with the accompanying risks becoming greater, there are definitely need for an ethical based approach to solve these issues. That is why a proficient surgeon is considered not only to be competent to perform the art and science of surgery, but also to be ethically and morally reliable. Definitely, we know that a good competent surgeon has to have good clinical skill, appropriate surgical judgment, technical skill, including the knowledge of and expertise in the performance of his duties. Let us try to understand how surgery is different from other faculties. This is in no way means to downgrade or demean other faculties, but definitely surgery has its own unique characteristics. Surgery can be defined as the action of man upon man. It can be conceived as both a passionate art where the matter worked with his living flesh, and a science where knowledge is dominated by power of action. The famous French surgeon Ambroise Paré, way back in 16th century, said that leafing through books on chatting or prattling about operation room means nothing if the hands do not put into practice that which reason dictates. That is why it is the power of action. Hence, it has been recognized that for surgeons, the main goal is not the knowledge, but the action. During a surgery, there is always an action by one person, the surgeon upon another person, that is the patient. The surgeons are therefore required to complete surgical procedures differing greatly from other medical specialties, where once a medical treatment is defined, it can continue with the direct involvement of without the direct involvement of the concerned physician. That is why in surgery there is a primacy of action over knowledge. Surgical ethics can be defined as the application of ethics to situations specific to surgical practice. There are specific ethical dilemmas and issues specific to surgical practice. In fact, if you'll see, surgery embodies several unique characteristics that justify the need for its own ethical approach. For example, surgery hurts before it heals. It is invasive and penetrates the patient body. And surgical decision is generally done under uncertain circumstances. Moreover, the field of surgery is rapidly evolving. Innovation, robotics are very common, making the surgeon face new and ever more challenging ethical issues. Hence, the aim of this particular deliberation is to reflect upon surgical ethics and their role in surgery today. So there are three axes which cover major realities of the surgery. Surgery is a discipline oriented towards action rather than speculation. Hence, surgeon needs ethics of action. And because it is related to the body considered as an object, there must be a well-done work of ethics. What are the virtues in surgical ethics? Decisions in surgery are based on appropriateness, acceptability, and standard of care. In order to make decisions, surgeons need to be virtuous in modest qualities. That is perseverance, punctuality, fairness, honesty, kindness, teamwork. These are very common values. But in addition, they also have to perform a technique sufficient to perfectly master the complex art of surgery. This is acquired during the extended education and then as repeated exercise in professional experience. Thus, this practical virtue is fed by discipline and perseverance, Most importantly, this virtue must be based upon the capacity of judgment or practical wisdom, that is phronesis, which is a disposition accompanied by a just cause turned to action and concerning that which is good or bad. So basically, apart from discipline, perseverance, the technicality, the knowledge, the capacity of judgment is one of the most important aspects in the ethics of surgery. In the virtues of surgery, we also need to discuss about the futility in ethical aspect, because surgery, any disproportionate or futile surgery must be avoided, and caregiver should not fall into therapeutic obstinacy. This can be a quantitative futility or a qualitative futility. Quantitative futility means if there is a study where it does not prove that statistically this particular procedure is going to be beneficial for the patient, then still should we go ahead and do it. What is qualitative futility? Qualitative futility is whether it is going to improve the quality of the life even after doing that surgery. Such ethical dilemmas are extremely common and faced day to day by all surgeons. Hence, it is very important also to understand that in ethics in surgery, the futility of the decision has to be always kept in mind. The surgical decision making basically is a two-part process. Is it possible to treat? That is how to treat aspect. And the second is why treat or what should be done. A very judicious balance has to be achieved in practicing the ethics of surgery. Taking decisions in terminal patient, refusal of surgical intervention, risk of futility, uncertainty about best treatment goal, and communication problems are few other aspects of ethics in surgery. Innovation, which is coming in a big way, which will be discussed by my fellow colleagues also, have created a lot of ethical issues relevant to the implementation of new surgical techniques and technology regarding the safety, timing, whether the patient are informed about the right choices, what are their complications, whether the surgeon is trained and what are the outcomes. All these views about newer technology has to be balanced, because we can't just rubbish everything that has been practiced as it is old and we will go all the way for new. At the same time, we have to have an open mind about newer technologies, newer things, and apply those innovative or newer technologies using the ethical principles so as to have maximum benefit to the patient and not to the operating surgeon or the hospital where he practices. And as we all know, the four basic principles, that is the theory of principalism, which everyone knows, the autonomy, non-maleficence, justice, have to be applied to the surgical principles also. We all know this. First, do no harm. We should act in the best interest of patient. The patient has the right to refuse or the treatment. The patient has all the rights. These are the rights, and justice has to be there in equal distribution of health resources. This principle of justice is especially useful when we are dealing the ethical dilemmas using newer technologies. Apart from that, respect for the patient, truthfulness, honesty, informed consent, confidentiality, all are well-known accepted principles which apply to the practice of ethicality in surgery also. Now let us try to apply this practically, the approach of principalism in surgery. The patient should be treated as autonomous agents. So he should be adequately informed about the benefits and risks of the patient's proposed surgical treatment. The patient has the ultimate right whether to accept or not to accept. The patient with diminished autonomy, where the patient suppose is in an unconscious state and requires some craniotomy, so his protection and rights, legal rights, are to be protected. Informed consent, I need not stress upon the importance where it has now gained worldwide into a dialogue, informed dialogue between the treating physician and the patient in the beneficence, obligation to act for the benefit of the patient. So we have to maximize the potential benefits for the patients while minimizing potential harm. Non-maleficence, obligation not to inflict. Here it's surgery. That is why, as I said, we inflict first harm, but that harm of the incision of surgery is to heal the patient. So that this particular principle has to be balanced very, very carefully. Because if the benefits of the proposed surgery are less than the side effects, then the surgeon has an obligation of not to operate. That is why all our great surgeons or teachers in the surgical field always say that a good surgeon is one who has the judgment of when not to operate. That best embodies what is the ethics of surgery. Justice, best surgical care has to be given, but again, we all know that now, to give you a concrete example, that robotics have come in a big way. But considering the massive expenditure in undergoing a robotic surgery, we have to judiciously advise a patient, considering his whole socio-economic status in toto, that whether to go in for robotic surgery or not. Not just because the hospital in where you are working has bought that expensive robotic surgery machine for crores of rupees and you are under pressure to give maximum patients for it. The 4-box model approach to clinical ethics is very much applicable to surgical field, whether your medical indications are right or wrong, whether the patient has been given adequate preferences, what is going to be the quality of life, and other contextual features, whether you have any conflict of interest, personal interest, financial incentives, or any professional biases. All these things have to be balanced to have a good ethical approach. Now let us try to understand the 5 categories within the moral domain of surgical relationship. They are the rescue, proximity, ordeal, aftermath, and presence. The sense of rescue, the feeling of relational proximity, the ordeal and the aftermath of surgery are things that the patient experiences. Surgeons must recognize the patient's need to be rescued. At many times, surgeons also need help and to be rescued by other surgeons or fellow colleagues in case of difficulties. The patient also has to develop a particular proximity with surgeons, what we call as faith. And this faith, this proximity will allow the surgeon to understand the patient suffering and specific needs. What are the implications and perspectives for the development of surgical ethics? Surgical ethics are an essential component in contemporary surgical practice. The success of even most technically skillful surgery requires an ethical approach. In fact, what makes a good surgeon is the balance of technical questions and surgical ethics reasoning. The acknowledgement of importance of surgical ethics, therefore, should have implications to the patient, surgeons, and the society also. As for the patient, they should also recognize the power of surgeon, a power which is socially endorsed. Similarly, the society and the institution should also be informed and be aware the particularities and challenges the surgeon face in daily practice. That is why, as this program is for in conjunction with MSN, JDN and MIMR, education of surgical ethics at the resident level is important for several reasons. First, it can promote humanism and professionalism based on human values. And in consequences, care would be delivered in a socially and ethically responsible manner. Education on ethics can contribute to making surgeons more culturally competent, It can also make surgeons better prepared to make ethical decisions they confront in daily practice, the application of new technologies, and in a surgical environment that is increasingly becoming institutionalized and under economic pressures and commercial interest. Resident ethics education provides the opportunity for a model of collective deliberation to be developed that can be used to make sense of ethical problems as and when they arise. An ethical curriculum should be a part of broader curriculum in humanities, and that is why we should thank Dr. Ved Prakash Mishra sir for his revolutionary concept of including the ATCOM module in the medical education. And that is why I also want to thank the entire bioethics program where run under the mission mode under the able guidance of Professor Karmi and Russell sir, where they have really sensitized all the walks of medical caregivers, may it be from nurses, pharmacists, physiotherapists, medical student, resident doctors, or practicing doctors, to sensitize and to make them understand what is ethics and what is the importance, need, utility of ethics. So, if we impart this ethics at the resident level, we can have that surgery will not only be conceived merely as a practice of applied technology, but as the humanistic art of healing. While dealing with this, let us also understand that these are ethics also of the healthcare provider. That the insistence that healthcare providers comply with patients' demands, regardless of the nature of the request and regardless of any conflicting demands on the healthcare provider's consciousness. And always remember, ethics is always a living document. It has to be dynamic. It is not monolithic. It is ever changing. And it is a field open to contribution from those with diverse insights. Apart from all this, there are general ethical considerations which are applied to the field of surgery also, that who is a qualified specialist, ethical regulation regarding advertisement, fee splitting and commissions, regarding health insurance, just distribution of resources, so on and so forth. Obviously, everyone knows that you can't claim to be a specialist, especially in the field of surgery where you have not have the required recognized degree, postgraduate training or sufficient skill and knowledge in that particular field. And finally, friends, good ethics is always good business. If you are more ethical, you are profitable in all aspects, not only in the material aspect, but on a spiritual plane also, on a plane of satisfaction also. Ethical conduct is always and always rewarding and satisfying. As I said, it is good business also, especially in the field of medical tourism. If you build faith, trust, as I said, ethics is the cornerstone of building good trust between doctor-patient relationship, and this faith, this trust is what basically heals the patient, because everybody applies the same surgical techniques. Nobody does appendectomy through a thoracic approach. Nobody does a gallbladder through a pelvic approach. Everybody by and large has to follow the same technicality. But what matters is how you deal with the patient in an ethical manner. And always remember, professional health, you have to be safe, and safe is always sexy. Ethical practice provides that safety. And you may say whether it is the Saint Peter or Chitragupta guarding your entry to the heaven, you may not get caught on this earthly world, but we all have to answer once you reach the doorsteps of heaven, where your balance sheet is kept of what good you have done and what unethical things you have done, because we don't want that any doctor's office is closed due to greed or due to unethical practice. There is no right way to do wrong thing. This is especially for my young friends, where they say that, sir, to survive in practice, we have to do unethical things. My neighborhood hospital, my neighborhood surgeon is doing unethical practice, so I should be doing it. No, don't go in for short-term gains. No reason can justify unethical practice. There is, if at all you are into it, please stop it, because there is always the time now is the always right time to do what is right. The surgeons should be skilled in the art and science of surgery and be trustworthy from an ethical and moral standpoint. They must recognize that the nature of surgical work provides fertile ground in which ethical problems can grow, and thus they need to be aware of and prepared for this. Surgeons should rely upon their judgment and their values and beliefs to make ethical decisions, and if necessary, to take difficult decisions to an ethical consultation or committee. In nutshell, friends, you should follow your heart. If your heart says that whatever I am doing is good, your conscience is not affected. When you go to bed, you feel that today whatever I did for my patient was very good from the ethical standpoint, then 99% you are ethically right. Lastly, always remember what Mahatma Gandhi, father of our nation, said, that the earth provides enough to satisfy every man's need, but not every man's greed. Don't fall into the trap of greed. There is everyone to satisfy. There is lots and everywhere things are there where you can satisfy your needs. But if you fall into the trap of greed, definitely you will not only have problems down onto the earth also, but once you reach the heaven also. Thank you, friends, for your patient listening. Your feedback on my email is most welcome. Thank you. Jai Hind, Jai IMA.
Thank you very much, sir, for a very excellent presentation. Good skills, and I would say you are a man of action. What you are doing, I would say that inspires all of the medical fraternity. So, with these kind words, being short of time, two things I just wanted to mention. We just said humanistic art of healing. It should be really that passion, so that we can rectify whatever has been done. So, with your, I would say, a dashing and a dynamic speech, we will turn to our other session with your kind permission. Okay, thanks a lot. Thank you very much, sir. Now I'd like to welcome our chairperson, Dr. Ali Pasnekar, now being a vice president, national vice president. So also in the past IMA state president. For next session or lecture, I would say, I would like to call upon Dr. Shivkumar Uttore sir, because sir has some appointments he has requested. Accordingly, I would request Dr. Shivkumar Uttore sir. He is the president of Maharashtra Medical Association. So also he is a member of NMC. I would say he inspires all of our Maharashtra doctors, and is every time after us when there is any of the issues. It's an inspiration, I would say. With this short introduction, I request sir to speak on challenges in telemedicine. Dr. Shivkumar Uttore sir, welcome sir.
Yeah, thank you, Dr. Sancheti. And at the outset, I must thank the organizers for having called me here today to talk on this subject, and especially when you're putting me Gurudev and Panditji, Dr. Ved sir, where we have learnt a lot from Ved sir. And you have to understand that basically ethics, which we never learned, unfortunately, during our formative days in the colleges. I think Ved sir has brought those ethics forward for the medical students also. Ethics, bedside manners, doctor-patient relationship, which has been introduced in the medical curriculum. was introduced under his chairmanship. So we have to thank him for having brought this to the new batch of students who will be coming up. So we had to learn our ethics, watching our seniors and learning from them. That is how we learned our ethics. And then, of course, my close friend, Dr. Ravi, who is a great activist of IMA, and Dr. Ramkrishna Londe sir, the president of IMA Maharashtra State, Dr. Derek, Madam Sharma, Sushma Sharma, and then of course Madam Shailaja Mane, Dr. Taide, and of course the chairman, Dr. Ravindra Kute. So thank you very much for inviting me here today. And today I have been basically asked to talk about the new aspect which has been introduced by the erstwhile MCI at that time. Can you see my slides?
We can see, sir.
Yes, sir.
Yeah. So teleconsultation and ethics. As I say, I as a person always like to see at somewhere in the dark clouds there is a silver lining, as they say. And one of the silver linings of this COVID era has been the introduction of teleconsultation legally and officially by the Board of Governors, which I think this document was lying for a long time and it required to be notified. And that was done during, if you see over here, on 25th of March 2020. And incidentally, let me tell you that because of the COVID era, I think one of the first councils all over India, that is the Maharashtra Medical Council, even before that, we had allowed officially our members to do telephonic consultation, which is part and parcel of this telemedicine, so that, you know, it would be helping not even only our members, but even the patients during this tiring era of COVID. So this document has been notified by the government and it has come into play on 25th March 2020, and it is named as Telemedicine Practice Guidelines, and it tells us exactly how to go about doing telemedicine. And let me tell you, since today a lot of JDN and MSN members are there, the youngsters, the tomorrow's doctors of India, these telemedicine is going to become the norm as it is in the Western countries in the future. So you have to understand telemedicine, you have to understand how to do telemedicine in future, and you have to understand the ethical aspects of practicing telemedicines for the future. Whichever field you are, it is not limited to only single field. Whichever field you are, telemedicine is going to help not only our consultants, our general practitioners, family physicians, but also the patients in the future. So very important topic, and I think I must congratulate the organizers for having asked me to introduce this subject. What are the ethical aspects in telemedicine? Now, what basically is the telemedicine? Up till now, as far as the MCI Code of Ethics was concerned, we were allowed only 1:1 examination and treatment of the patients between the doctor and the patients. But telemedicine has brought an interface between the doctor and the patient, and that interface could be your telephone, could be your mobile phone, or could be a computer, whatever it is. So basically what it has done is the actual contact, physical contact between the patient and the doctor is not required in future practice of medicine. And the greatest advantage is that telemedicine provides 24/7 lifeline for patients to connect with their providers. This offers great comfort and assurance to the patient, especially during the COVID times. You have to understand there have been multiple cases in the court of law where punishments have been given to our doctors because they have done telephonic consultations of the patients, because it was not allowed legally. But today, because of telemedicine being notified, this is allowed legally, and that is the biggest advantage in these tiring times and even for the future. So what telemedicine enables you. So what it enables is the faster access. These are the advantage first I will talk about before I come on to the ethical aspects. Why telemedicine is an advantage is because it allows faster access and access to services that may not otherwise be available. That means if you have a senior consultant or a super specialist who is sitting in Mumbai city, and you have someone say in a remote place like Gadchiroli or interiors of Chandrapur or something, for him to travel all the way to Mumbai would have been very difficult and taxing not only to him but to the whole family. But today, because of telemedicine, he is accessible. The doctor who is sitting in Mumbai, the super consultant, or the consultant is accessible to him. So that saves a lot of cost and effort, especially for the rural patients. Not only that, but remember, we are Indians are very emotional breeds. And therefore, you see that when a patient comes into a hospital, he is always accompanied by 2, 3, 4, and sometimes more than that, relatives also. So this telemedicine will reduce the inconvenience and the impact on these families. Not only that, it minimizes the likelihood of missing out advice from the doctor, because everything will be documented in telemedicine. Very less will be left to hearsay, as we say in legal terminologies, that the doctor has said something to the patient has not understood, and the patient does something different for which he suffers. So that will not be there. We will see how that will not be there in the future slides. Then the exact documentation of the advice which is provided by telemedicine, because this is either in a photographic forms or it is either in a recorded form. So the patient can always fall back on that if he has not understood what the doctor has said during the teleconsultation. And this gives protection to the doctors also, because no more the doctor has to prove what he has told or what he has advised the patients. So it is there recorded in telemedicine. So it provides the patient safety as well as health workers safety also, because especially during these COVID times, you don't want to come in physical contact. Let me tell you my own experience. Just 3 days back, I had a patient of pain in abdomen. I'm basically a surgeon whom I saw, and while examining her, she started coughing, and I simply asked her, for how many days do you have this cough? And she said, at least for 3 days. And I advised her to please go and get herself examined, RT-PCR test done. After 48 hours, I got a phone call from her saying, doctor, my report has come positive. So this is what we are exposed to as healthcare workers, and that will stop if we can do more and more patients on teleconsultations. So what telemedicine basically does is it improves access. Cost efficiencies are there because the patient does not have to travel all the way. Improved quality of care, because you can suggest to a patient a lot of other ways and means by which he can be treated. And then of course the patient demand is always there, because he doesn't have to come during those 2 hours of consultation time of the doctors. The doctor is available to him 24/7. So let us see some of the provisions which are there in this teleconsultation, which has been notified and which we have to follow as far as practicing in India is concerned. Now, telemedicine allows us to practice from any part of India. That means, as I said, I can be sitting in Mumbai, and tomorrow someone in Agra wants to do a teleconsultation with me. He is allowed to do that teleconsultation legally. And while uphold the same professional and ethical norms and standards as applicable to traditional in-person care. This is most important thing, because we are talking today on ethics of telemedicine. I'm not going to go into the details of the ethical aspects, because many of you all know what are the ethics as far as traditional in-person care is concerned. I will stick to the ethical aspects of teleconsultation, which is in my future slides. So one thing you have to understand, that today you have been allowed to do teleconsultation, but if you want to continue to do teleconsultation, within 3 years, a mandatory online course is going to be notified by NMC. You are supposed to finish this mandatory and pass this course, and after 3 years, you can practice teleconsultation only after you have passed this online or you have done this online mandatory online course on teleconsultation. So keep that in mind, because you should not forget that down the line, within 3 years, you'll have to do this course in the future. So tell him what are the applications as far as these teleconsultations are concerned. So basically you have to understand, and all this is documented in the document of telemedicine, that the mode of communication can be three. It can be video, it can be audio, or it can be text mode. That means what basically we do by SMS or by WhatsApp or whatever it is. Then of course it defines what is the purpose of the teleconsultation. You can do emergency consultations, but emergency consultations can be done only where the patient does not have any alternative care available to him where he can physically attend, and it should be for immediate first aid assistance for the patient. It should not be a full teleconsultation in emergency. Non-emergency consultation is divided again into first, what is known as first consultations, where you're supposed to diagnose, treat, or give health education and counseling to the patients. And then of course, follow-up consultations. Why this is important? Because what you can do during the first consultation and follow-up consultation has also been defined as far as these documents are concerned. Then how do you do teleconsultation? So teleconsultation can be basically between the patient and the RMP. It can be between a caregiver to an RMP. That means a caregiver can be any person at home who's looking after that patient over there, or it can be between an RMP to an RMP. That means today, instead of say family physician, when he sees a patient and he feels that a consultant's advice is required and examination is required, he can sit over there beside the patient and log on with the consultant, and he can be the intermediary between the patient and the consultant. So this is also allowed, and so it basically becomes a tripartite consultation between the patient, the family physician, and the consultant. And then of course can be between the health worker and the RMP, especially if you see in small villages where you have the health workers who are over there, or you have the nursing staff who are over there. They can also have the advantage of taking teleconsultation of any senior or any consultant. And what you have to understand is that they have written down what drugs can be prescribed. It is not going to be just like how you do physical consultations where you can prescribe all the drugs. It has been noted down that which drugs in which situations you can prescribe. So if you see over here, it is divided into video consultation and non-video consultation. Very important to understand. So in non-video consultation, again, it is divided into that there is no prior in-person consultation. That means you have not seen the patient prior who has come physically to you and got examined by you. And of course, where the prior in-person consultations are there. And then you have a list which is called as the O list, A list, B list, where they have said which drugs can be given and which drugs cannot be given. So if you are going to do where there is no prior in-person consultation and you are doing a non-video consultation, the drugs which are listed under the list O, you can, I'm not going to go into the details of what drugs are there in these lists because it's a huge, it will take a lot of time. You can go online and see if these are notified over there. So you can give only list O drugs. So basically these are the OTC drugs like paracetamol, oral rehydration drugs, antacid, and all these drugs which are there. But if prior in-person consultation has already been there, then you can, to this is added a list B also. That means suppose a patient of, diabetes, hypertension, asthma, these patients you have already seen priorly, come to a diagnosis prior, you have done that, and then you want to do further consultation where you require to change the drugs or increase the drugs, then you can do this. And these are known as where prior in-person consultation has been done. Then of course, video consultation, if you have done the video consult, if you are doing the video consultation, there also it is divided into no prior in-person consultation and prior in-person consultation. and with no prior consultation, you are allowed to prescribe list O and list A drugs. And here basically you have all these skin disorders, give an example, skin disorders or eye drops giving, all these can be done because you require to see these patients on video to diagnose what those skin lesions are or the ophthalmic problem is. So just as an example, I've put over there. And then of course, where prior in-person consultation has been done and you're doing the video consultation, you can give list O, list A, list B. Now, habit-forming drugs and narcotics were not allowed to be given as far as the first document came out. But then subsequently, there has been an amendment, and then some drugs, some psychotropic drugs are allowed as far as teleconsultations are concerned. Then, of course, there are the 7 elements if you see whenever you're doing a teleconsultation. The number 1 is the context. And when we talk about context, it is left to, every individual practitioner should have exercised their professional judgments if you require or you can or cannot do this teleconsultation. And the first thing that is most important when you start this teleconsultation is the identification of both the patient and the medical practitioner. That means when a patient comes online, the first thing I tell him is, I am Dr. Shivkumar Utture, I am a surgeon, and I would like to know your identification also. And I tell all my colleagues that it is always best to take an Aadhaar card, ask him to send an Aadhaar card to you online, so that you can identify the patient, so that there is no misuse of whatever prescription you are giving to a particular patient. Then of course, mode of teleconsultation we have already spoken about. Then most important ethical aspect is the consent that you have to take. Now you have to understand, when this teleconsultation is initiated by the patient, that means there is already an implied consent which is there, that the patient, just like in a physical consultation, the patient is allowing you to, on say video or on telephone, the patient is giving you the history and the patient is allowing you to prescribe medications. This is called as implied consent. But you have to understand that if there is an interface person between you and the patient, like how we have seen, where you have an RMP in between, where you have a caregiver, or you have a medical personnel or paramedical person in between the patient and you, in such a situation, you require to get an explicit consent from that patient, where you record it and document it by asking the patient that such and such a person is going to be between you and me as far as this teleconsultation is concerned, and I require you to give your explicit consent for me to go ahead with this teleconsultation. So please understand this difference, which is completely different from what we take consent from a patient when we are doing actual physical consultation. So implied and explicit consent, these are the 2 consents which are absolutely required whenever you're doing teleconsultation. Then of course, exchange of information for patient evaluation, most important thing. If an RMP feels that the information that he receives from the patient is inadequate for him to give a diagnosis and treat this patient, you must stop the consultation there and there, and you should ask the patient that, no, I require to see you physically, or if he is a patient who's far off, you ask that patient to see some doctor physically to come to a diagnosis, and then you can have the RMP to RMP consultation with that particular doctor. So that is left to your judgment to decide when to stop this consultation. Not only that, as far as prescription is concerned, remember, prescription should not be typed on WhatsApp and sent to the patient, because these prescriptions can, once it goes into the hands of the patient, they can change these prescriptions, they can change the number of days, they can do a lot of changes, and then you are in soup. What you should do, that the prescription should be written down on your prescription pad, and what are the things that required, I will come in the next slides on the prescription pad. you take a photograph of this prescription and you take a PDF copy of this prescription so that it cannot be tampered by that patient, and only these prescriptions you can forward to the patient. Not only that, in the Western countries, they are allowed to send or transmit this prescription directly to a pharmacy. It has not yet come in India, but definitely down the line it is expected to come. And here also you have to understand that if you are going to transmit this prescription to the pharmacy, you require to take explicit consent of the patient who allows you to transmit this prescription to the pharmacist. This is going to be for the future that I told you. So only you are allowed to provide a photo, a scanned copy, a digital copy, a signed prescription, or a e-prescription in a PDF format which you are allowed to send to the patient. And this is what is ethically right for you to do. So what are the responsibilities as far as all these things are concerned? So as I said, the medical ethics as of now, the details have, as far as telemedicine is concerned, have not been notified. But then all the principles of medical ethics which have been put up in the Code of Ethics 2002, those principles are there, which have to be followed for telemedicine also. Along with this, I'm not going to go into the details because majority of us know those principles. What you have to understand that even those provisions which are there in the IT Act, the data protection and privacy laws are also applicable whenever you do telemedicine. Hence, as RMPs should ensure that reasonable degree of care is undertaken during hiring such services, where you have an intermediary or you have a platform where you give this teleconsultation. That platform should not misuse the data of that patient, because as you know, the doctor-patient relationship and is a sacrosanct relationship, and whatever the patient tells you in confidence should not be divulged to a third party. So IT Act, Data Protection Act, and privacy laws are also applicable along with the Code of Medical Ethics to you. So what is misconduct has also been defined in this. So actions that willfully compromise patient care or privacy and confidentiality. Then other thing is that if you're doing teleconsultation and the patient says, no, doctor, I require to come to you, I will be satisfied only when you examine me, there is no way that you can insist on only telemedicine. So either you tell the patient, if you're not able to see him physically, that no, you can go to some other doctor, or you can ask the patient to come to your consulting and you can examine the patient physically. Then of course, misusing the patient images. Remember, especially in video consultation, you are face to face with the patient, you see the patient, you identify the patient, and if you have video recording all these things, tomorrow especially, some doctors have got a habit of, in their medical groups, putting up these videos of this patient, that I treated this patient which was a complicated patient. Remember that if the identification of the patient is going to be because of your video recording or because of your photographs is going to be revealed, then of course this will be taken as misconduct against you. Then of course, prescribe, we have already seen, you have to prescribe medicines from the specified restricted list, that is a list O, list A, list B, which we have already spoken about. And of course, any advertisements and inducements are also not allowed as far as telemedicine is concerned. And the penalties which have been described as of now are as per the prevailing laws of the IMC Act and the ethics. So log or record of telemedicine interaction between the patient and you have to be kept. Patient records have to be preserved by the doctor. This is the onus of the doctor. Remember, today in physical, whenever the patient comes to me to my OPD, I give him the OPD file which contains all the details, and it is the onus is on the patient to keep these physical records. But when you're doing telemedicine, you have to maintain these records, and that the onus is on you. Therefore, many doctors, I tell my colleagues who are not, very apt and as far as telemedicine is concerned, then I request them to go on a platform. There are ready-made platforms which are there via associations or some platforms which allow you to do telemedicine. you do telemedicine on that platform, because they do all this job of keeping the records of these patients. Then of course I am asked up till now, whenever the patient used to telephone me, I used to never charge these patients in the past. But today under this telemedicine, you are allowed to charge an appropriate fee, and you're supposed to give a receipt or an invoice for that. And what is an appropriate fee? This is what is also asked to me by many of my colleagues. I tell them simple thing: the appropriate fee should be always equal to or less than what actually fees you charge when you examine or consult a patient in a physical format. It cannot be much more than that, remember, and that is what appropriate fee is. And then of course, prescribe medicines after you are fully satisfied that you have come to a diagnosis on teleconsultation, and you have gathered adequate information. Then prescribing medicines without an appropriate diagnosis or provisional diagnosis will amount to professional misconduct, and you may be hauled up by the court or by the councils tomorrow if you don't come to a diagnosis before prescribing the medicines. Then of course, the RMP asking another RMP's advice. So who is responsible has also been defined in this telemedicine document. It is the primary RMP who is sitting with the patient is responsible ethically for the patient. And why I tell you this? Because he is the one who is actually examining the patient, and his examination findings are then relayed to the doctor who is sitting at the other end of the telemedicine. And therefore, what details he gives, the consultant will give you his diagnosis and his prescription accordingly. So the primary responsibility will be of the RMP who is sitting with the patient over there when it is an RMP to RMP teleconsultation. Then of course, emergency situation, I have already told you where you can do it, to what limitations are there, and you should always insist that the patient goes to an hospital or a doctor in an emergency and not sit at home on whatever primary first aid you have given to the patient. Then of course, the guidelines for the technological platforms are also given over there, and you have to remember that they are obligated to ensure that the consumers are consulting with a registered medical practitioner only. That's very important. Remember, telemedicine has been notified only by NMC or MCI before this, and so only if you are registered under MCI Act or the State Medical Councils Act, or like the Maharashtra Medical Council, you are today allowed to do telemedicine. And that is what the technology platforms have to guarantee that patient, that you are a registered. So they have to take those details from you before they allow you to come on that platform. Not only that, artificial intelligence and machine learning is not allowed as of now to counsel the patients or prescribe any. So that means the human, maybe not the touch, but the human interface between the consultant and the doctor is maintained over here. Not only that, it has also said that the technology platform which is found to be violating any of these conditions, they will be blacklisted. But then it becomes the onus is on the RMP to know if he is there, his technology platform is blacklisted or not. And if it has been blacklisted, he should get out of that technology platform. Now the exclusions are there, and the exclusions that digital technology to conduct surgeries or remote controlled surgeries or any invasive procedures is not allowed as far as telemedicine is concerned today. And the other thing is that you cannot consult someone who is beyond the jurisdiction of the borders of India. That means suppose you have a patient who is, say, goes on a holiday and he goes to Europe or USA or say Middle East or wherever he is. Remember, as of today, you are not allowed to do teleconsultation to these patients as per what is being noted down in the notification today. So you are allowed to do teleconsultation only for those patients who are between the borders of India. Now, what your prescription format should be there is also notified in this. So it's not necessary that you stick to this, but whatever the columns are there, all those columns have to be there whenever you are giving a prescription. So your name, your registration number should be there, your qualifications which is registered with the state council should also be there, the details of the patient's name, age, sex, everything has to be there, and then of course what drugs you are writing down, those should also be there, and this should be a scanned copy or a photograph copy which you should, or a PDF copy which you can send to the patients. So what are the do's and don'ts? Basically, just in a nutshell, identification is mandatory both of the RMP and the patient, and it has to be confirmed. But if there is a follow-up consultation, it is not mandatory to every time when the patient comes that you have to identify this patient. Then caregiver identity and authorization should be checked. That means you have to be registered practitioner under the council. Only then you are allowed to do teleconsultations. Then when you start the teleconsultation, you have to first thing that you do is you have to identify yourself to that patient and then take the identity of the patient. Your registration number should be there so that the patient knows that you are a registered practitioner. Do not continue teleconsultation if you find it is not appropriate and you cannot get all the details from that patient. The records of the teleconsultation, the onus is on the RMP to keep these records with him, may it be in a digital format or whatever. You have to keep these records. The patient's data should be sacrosanct. It should not be disclosed or transferred without the written consent of the patient. You should deny emergency teleconsultation. Only you can do where it is life-saving and first aid that you can give the patient. Then, of course, limitations of prescriptions, which I have already told you. You have to limit yourself to the prescriptions as per what type of teleconsultation you are doing. That is, prior you have seen the patient or not. Are you doing a video consultation, or it is on a telephone, or it is on, say WhatsApp or some other media? You are allowed to do only those type of prescriptions which are listed in the list O, A, and B, which has been notified. So thank you very much. In short, I have tried to cover up, which is a huge topic, a huge document. In short, I have tried to cover up all that, and I hope it will help, especially our youngsters who tomorrow are going to go in a big way into teleconsultation. Thank you.
Thank you very much, sir. It was, I would say, an excellent and eye-opener presentation for telemedicine. Actually, there are many doubts also. There are, I think, 2 questions. But as you said, PDF copy of prescription should be scanned. I think this is a very important thing to know also, and preserve the documentation. We talked about video, audio, and texting also. And about the course also, you said we have to complete a mandatory online course within 3 years. So I think it is better that our doctors and students should know exactly what type of online course they have to undergo such type of course or something from MMC.
No, that course has not yet been notified. It will be notified by NMC. That is why 3 years they have given you. I think down the line, I think within 6 months or so, that course should be notified by NMC. It will be done by the National Medical Commission.
Thank you for this information. And I think there are 2 questions. One is by Dr. Santosh Pancha. Major disadvantage of teleconsultation is that patient can file a case against doctor at his or her place. Anything to avoid this? Major disadvantage of teleconsultation is that patient can file a case against doctor at his or her place. Anything to avoid this?
No, there is nothing to, I don't think it is, you are able to avoid that. And if you understand that even otherwise, as per the new amendments which are there in the CPA, the patient can file a case against you even if he has done physical consultation with you from the place in which he is. So this is not only restricted teleconsultation. Unfortunately, this is there for even physical consultations. And that is why the documentation is the most important thing. And therefore, I say that please, if you can't create your own platform, at least join a good platform which is made by your organ. Many association, doctor organizations and associations are preparing these platforms. You can join that so that all this documentation is kept properly, because that is what is going to help you tomorrow if the patient files a case against you.
Thank you, sir. And second question, if a patient gets some non-urgent but severe problems during lockdown, irregular PV, blackish bleeding, how can video consultation be done? Most irritating problem for OBG people, please advise.
As I said, if it is an emergency, yes. If it is life-threatening or limb-threatening, you can give advice on teleconsultation. Otherwise, no. And the advice that you basically give is only meant for first aid treatment of, suppose you have got an injury, how to stop the bleeding, or if there is a fracture, how to give a splint. All that you can give, so that and immediately you also document that you have advised the patient to go and physically go to a hospital or to a doctor and show whatever the problem the patient has.
Thank you very much, sir. And I request all the doctors, if there are any further questions, they can send a mail to sir. Is it okay, sir?
Thank you.
Thank you very
Can I
much.
say something, Dr. Rajan?
Okay, sir.
A very excellent talk by our friend, which is very relevant also. And especially regarding the last question, in emergency, everything is allowed, provided you have a good done in good faith. It's a well accepted principle of law. Everything done in good faith. That is why ethics is more important.
Yeah.
If you have that trust, then otherwise, whatever you do, even following all the procedures, if you don't have built the trust with the patient, you are going to face problems. So that is why I just wanted to say that ethics do form the cornerstone, and in all routine aspects, whatever Utture sir has said, we have to follow that. But in emergency, when you are flying in a plane, you can conduct deliveries. In a roadside accident, even if you are an ophthalmologist, you are supposed to give primary care. That time you are not liable for anything. So that was my just humble opinion. Thank you.
Dr. Rajan Sancheti sir, can I say something?
Please, sir.
Hello. The thing is that
please go on.
telemedication is in the process from the last so many years. Its benefits and its negative effects, we are watchful for it. But at the same time, taking into the corona pandemic consideration, it is and taking the corona positivity into the consideration, we have to much more watchful. And at that time, this telemedicine is a boon for our association. And Dr. Sukumar Utture sir has very well appropriate.
Sir, voices
About the telemedicine. So I'm really thankful to Dr. Sukumar Utture sir for enlightening us and giving a great take-off message about the telemedicine. Thank you very much, sir.
It was a very important, I would say, presentation, and I hope everyone enjoyed, because I have some queries also, but we can take it later. Thank you very much, sir, for your kind guidance, and in future also, I think all the doctors and students who need help, we can get it through you solve. Thank you, sir.
Thank you.
Can we go ahead, Paznikar sir? Paznikar sir had given his, I would say, one of the best services in Dharavi. He's the chairperson now and had been a corona warrior also. All of the faculties, even Dr. Utture sir, Dr. Vankadkar sir, they have done, I would say, wonderful job. And we all appreciate and get inspired by all our stalwarts. Thank you, sir. So we go for a next session, next lecture.
Sancheti sir, sorry to interrupt. Hello.
Yeah. Yeah,
Dr. Alka, there is one Dr. Alka. She want to talk something. Can we allow her? Utture sir, can we allow her?
That's left to the organizers to decide, not me. I was speaker.
Whatever, just we can have it fast, because we are also having some appointment. So, Dr. Alka, please make it fast. Dr. Alka madam. So we can answer it later, as we have to go further, short of time. So With your kind permission, Dr. Uttare sir, can we move on?
Yeah, please, please. I think we are
Thank you,
late.
sir. Thank you.
Madam is waiting
Ma'am
for a
is,
long time.
yes, ma'am
Okay,
is
thank
online.
you. So I request our next speaker, Dr. Sushma Sharma, who is Professor of Department OBG, MIMR College, and she will speak on challenges facing women's health care in the present scenario, a very important topic because in COVID, it is really drastic. So I request Dr. Sushma Sharma, madam, to start her session. Thank you.
A very good evening, everybody. At the outset, I would like to thank the organizers for this opportunity, for making me one of the speakers in a very meaningful and much needed conference, which is the need of the hour. And all of us, like we have been hearing since the beginning, are now in the middle of this pandemic, isn't it? My previous speakers have been stalwarts and they have really spoken elaborately on various topics. Me being from the field of OBGY, I'm going to speak about some of the challenges which we have been seeing and which people who provide healthcare all over the world to women have documented in some articles. So in any pandemic scenario, what happens is that the duty of care shifts from the individual patient to the safeguarding the health of the community in general, isn't it? And very rightly so. The individual loses importance and it's the community at large which becomes the center of focus, and therefore the duty of the healthcare also shifts accordingly. Now, on these lines, both the government as well as healthcare systems, all of us have been part of these organizations and have had to make difficult policy decisions. And in this COVID-19, in the past year and almost 4 months of the current year has gone by, it has highlighted certain unique challenges in women's healthcare. Among them, we have seen that there is a kind of devaluation of women's health. Now, someone would wonder what makes me say so. So, a small example would be, the shifting of elective surgeries to the more safer time. Now, everybody agrees to that probably a hysterectomy is not a life-saving surgery. But if you think of that particular individual, that particular woman, it may have long-term resultant ramifications on her health as well as the health of her family. Now, women health services are provided not just by gynecologists, it is also provided by family physicians, general practitioners, midwives, nurses, traditional birth attendants, etc. Now, health issues where women are concerned are from the entire lifespan, right from the time that she's a girl to the time she ends her life, right? Now, this includes certain issues which are related to sexual and reproductive health. And we know that in the one of the hallmarks of women's health would be pregnancy and lactation. And not to forget prevention and treatment of cancers, especially breast cancer, cervical cancer, which we have been seeing are quite on the rise. And all the societies around the world, the gynec societies, as well as organizations like the IMA have taken up this cudgel in a big way in trying to prevent cancers. Now, the World Health Organization declared the year 2020 as the year of the nurse and the midwife. This was done so that we highlight their role in the healthcare sector. And this has become extremely evident during the recent and the ongoing COVID-19 pandemic. We all have seen and we see all around us in our own setups, we've seen this globally, how much these nurses and midwives have been contributing to the healthcare of women and to general healthcare also, not just healthcare of women. In fact, there are just trained midwives who have been roped in to provide care to these COVID patients also, and they are living up to it, I must add to that. Now, I've chosen a few of the challenges which are faced during this pandemic with respect to women's healthcare. And among them, I would like to highlight the antenatal services and the continued care which a pregnant lady needs. Now, this figure is from the UNICEF's estimation that there will be 116 million babies which will be born during the pandemic and in the immediate aftermath. So you can imagine that there'll be millions of women who will be needing antenatal care services. Now, the fear about transmission of COVID. Now, we all know that the antenatal period, be it in any society or any community or country, it's a very sensitive condition, isn't it? We are more than concerned about the health of not just the lady, but of her growing fetus in utero. Now, so the fear of COVID infection and its transmission, which exists in everybody, kind of magnifies with respect to these pregnant women. And this has called for rethinking of certain set standard protocols. For example, I would like my antenatal patient to come to me, and then I would like her to go for the ultrasound and come and show me the report immediately. Then I would like her to undergo certain lab tests and come with the lab report so that I can counsel her as per her hemogram, etc., about her diet, what activities she should do. And this develops a bond sharing and gives confidence to her about the rest of her pregnancy. So now these set standard protocols about the visits all has needed rethinking, and we have had to employ new methods of patient care. So therefore, we kind of have reduced in the number of actual visits to the OPD. If you look up now, people have tabulated the data from around the world, and the number of antenatal visits have been reduced. If you look at an advanced country like the United States of America, as well as the urban population of even our own country, an average pregnant lady visits this was of course in the pre-pandemic era, she would visit the antenatal OPD on an average of 10 to 12 times in the entire 3 trimesters. Now, this has been reduced to almost down to 3 to 4. In fact, this is way below the minimum that the WHO now prescribes as 8 visits as the minimum to be a standard for antenatal care. So, reduction in the number of antenatal visits to the actual OPD, and then relying for the other things on the use of telehealth facilities. So, what happens to the monitoring of the patient at the times that she's not coming to the gynec OPD? Well, we have had to rely on self-use technology like BP apparatus. Then there are easy-to-use fetal Dopplers with which the patient can herself listen to her fetal heart rate and maybe transmit it on to the teleconsultation on the other side of the screen or the telephone or whatever the scenario may be. Now, big leaps have been taken on these lines. We had a very beautiful, elaborate deliberation by Dr. Utture just now. Even the government of India and the Digital Health Mission has taken it up and has expedited the legalization and the norms and tried to incorporate it as something which can be reached by all. Many telehealth services can be delivered via telemedicine both during and after pregnancy. So antenatal care with respect to monitoring of weight, blood pressure, fetal heart rate, as I was mentioning, blood sugar, other lab reports like hemogram, blood group, it can be done. Now, consultation with specialists if needed. For example, if the need arises, one can consult a genetic counselor or a feto-maternal expert for that. So you can have virtual prenatal cares, and you can have online communication with the other healthcare providers like mental health care providers, because pregnancy is per se definitely identified as a stressful condition. And during the pandemic, we know that any average person has had increase in the levels of stress. So an anxious pregnant woman definitely has certain demands for mental health care solutions, and that can be provided on the digital platform. The same thing can also be done once the baby is born. You can have lactation support and you can have virtual postpartum visits. Now, what are the challenges? So we saw what we have tried to do in order to modify providing healthcare to these women. The challenges are that it requires initial intense patient education, isn't it? If you look at the average Indian lady who comes to any of our OPDs, then the level of average literacy and more so digital literacy remains much to be desired for. And there has to be strict adherence. Sir kept on talking about it, and that was probably the answer to most of the questions. It requires robust documentation. So not just you, but your patient at home, when she's self-monitoring, needs to do robust documentation of her own findings. Now, how much this is possible remains a challenge. Now, this kind of antenatal care is suitable only for normal and low risk pregnancies. And high risk pregnancies are on the rise. And this is not suitable. This model of antenatal care is not really suitable for these high risk women. It also raises concerns about missing out on some key events, the crucial things which might be happening and maybe having an effect both on the pregnancy itself and very much on the fetal as well as the baby to be born, that is the neonate's health. Well, the digital platform is excellent. It provides a lot of solutions. The government is trying to do a lot even in our country, but not all socio-eco settings has the ability or the availability to implement the self-monitoring gadgets or the paraphernalia which is needed for digital health, be it a smartphone or a laptop or a internet connection. Me working in a medical college which is situated in a rural area of Pune, although it is just 35 kilometers off Pune, I'm much witness to these kind of situations where there is definitely a huge digital divide between communities with respect to availability as well as ability to use it. So one size fits all is not a solution over here. So this remains a challenge as well as a concern. So how do we in this current scenario deliver healthcare to women over here? Again, the question was rightly put up by a gynecologist. The video interface may not be comfortable for women to show themselves as they would show in their physical form to a gynecologist. So OBGYN examination is something which, of course, takes a lot of the woman's privacy into consideration. It's not just the examination. Women are very concerned about who else is there on the other side of the screen. If you would visit any gynecologist's OPD, you'd see that the area in which the lady is examined is well cordoned off by screens or curtains or partitions. Now, there remains a question in the woman's head about who else is there on the other side of the screen. And as Sir was pointing out, in video consultation, many times we record, and so that raises all kind of doubts in the patient's mind. And so it remains again a challenge for us. Now, a practical solution to these kind of situations, which we have adopted in our institute, would be to combine services during a single visit. For example, she comes for her consultation. In the same visit, we go ahead with ultrasound and we go ahead with the lab reports. We do a dietitian's consultation. We let her meet the physical therapist who teaches her simple to-do exercises at home. And we try to call them as per the gestational age. For if I need an anomaly scan at 18 to 20 weeks, that is when I'll call her for a consultation. And so all these can be combined during a single visit. Again, in the postpartum period, we combine that visit with the baby's immunization. So when she has to anyways come to the hospital for immunizing her baby, that is when we do her postnatal checkup. So there is a little deviation from the norm. I may have liked to see her at 7 days postpartum, and then again 2 weeks and 6 weeks. It may not necessarily be so. So we have to now modify our protocols to these new normals. What remains and continues to remain a challenge is providing services and care during the actual process of labor or the intrapartum time. We all know that labor takes hours, isn't it? If you will, even if you consider the average well progressing labor, around 6 to 8 hours is what I would pin it at for an average between a multi and a primary if she comes in active labor. So you can imagine that it requires long hours of patient contact. And there had been certain question marks raised whether labor really is high risk for transmission of the coronavirus. Well, it has been proven that the second stage of labor definitely is aerosol generating. So it remains a health concern for the care providers in the labor room. And anybody who has put on a PPE will 110% agree to the fact that it is extremely difficult to maintain wearing a PPE and close masks for such long hours. What we have done is then we have kind of made shifts in which we give the over of the patient to the next person. So a PPE at the most can be worn probably comfortably, and the doctor or the nurse not feeling faint and giddy or getting their bladder full would be around 8 hours, 6 to 8 hours. Right. And in these kind of summer conditions, probably even shorter. So what we do is that we prepare a relay team. So we pass on the baton to the next person. So probably this can be a practical workable solution, but then of course we stand the risk of exposing more and more people to that one single patient. Probably there's no emergency like obstetrics, and in certain situations we demand expediting the patient management. Imagine a head-on perineum, or imagine a fetal heart rate which is dropping to 60, 50. Then sometimes we have to rush and provide the patient care where we don't even do the rapid testing for COVID. So this remains a concern as well as a challenge, and there doesn't seem to be much solution. We all are ethical practitioners and continue to be so. So this emergency situation in obstetrics does put up a certain challenge to all of us. Now, these are some of the other two situations which have really taken a backseat, and it is going to have immense repercussions, which we'll probably see in the upcoming time to come. And of that, I would like to draw your attention to providing access to reproductive healthcare services. And in that would be contraception and MTP facilities. Now, these services oftentimes have gotten postponed because of the concern of infection. All hospitals, if you look at Pune city today, I don't think there is a single hospital which is in a comfortable situation to deal with elective patients. So what happens to this particular lady who has, or girl who has come for a termination of a pregnancy or who wants contraceptive advice? So definitely she takes the back seat, isn't it? And then she resorts to something with her half knowledge and goes to buy some over-the-counter medicines which she or the local pharmacist feels suitable, and ends up maybe with some wrong advice. So we should start putting thoughts to at least things like emergency contraception, preventing unwanted pregnancies. Maybe instead of only the gynec OPD providing it, we could start providing these things at every casualty. At least I would definitely urge everyone to start providing for emergency contraception. instead of wrong over-the-counter pills. A very alarming thing which has been seen and reported adequately and globally, not just in our country, but globally across the world, is an increase in both domestic as well as intimate partner violence. It's a very sad thing, but these forced lockdowns have made an increase on the demand of sharing the same physical space. And women, if you read these articles, they have reported domestic violence at the same simple thing of, we all had that period, we all again have that period where there is no domestic help to help in the household chores. A simple request of sharing the workload has ended up in many situations with domestic violence. Now, we have kind of again not been able to provide adequate support to these survivors of violence. So we definitely need to take a look at this. We have very beautifully designed these one-stop solutions where, the sexual violence survivor does not need to go from pillar to post for every care, where this one center which provides her with the testing, filing the report, with psychological counseling, rehabilitation, providing emergency contraception, MTP if the need may arise. But in the situation of this pandemic, all these centers have come to a standstill because we can't afford to have healthcare workers dedicated to centers like this. They've all been shifted to the main COVID care. So again, why not double up our emergencies to provide these services? And I would sincerely urge organizations like the IMA to take up this particular aspect, something very close to my heart, and I'm sure to the heart of most women and people who care for women in the healthcare sector. So we should start thinking on providing this kind of support and care, and not treat it as something which is unimportant just because there is the pandemic looming large over our heads. No doubts the pandemic is something which takes priority over everything else, but because these things can have really long lasting damages, physical more than physical, emotional, as well as on the mental health. All right, now where it comes to ethical challenges in women's healthcare, we all know that all ethical committees define women as, definitely pregnant women, as a vulnerable population with respect to research. Now, what has happened because of this is that both pregnant as well as lactating women remain excluded from all new drug trials. So, even if she is a COVID patient herself, she is not included in the new drug trial. So, the pregnant woman remains deprived, if I may use the word, of being enrolled in any of the drug trials for them. We all are still grappling with what is the most effective way to treat COVID-19 SARS infection. And therefore, more and more of trials are going on. Unfortunately, pregnant women and lactating women are not part of that. Now, where it comes to the vaccine, some parts of the world have permitted that pregnant women who are healthcare workers themselves should undergo vaccination. However, the government of India very clearly in January 2021 has enlisted that pregnancy and lactation is a contraindication to the COVID vaccine. So we may need to revise this as more and more evidence comes in. So here remains the ethical dilemma. We do not know the effect on the fetus, on the embryo, or on breastfeeding. Therefore, this contraindication enlistment for the vaccine. Well, hopefully, this will need a change, and we will see that change come soon. Women's mental health in the pandemic. If you look at studies coming in from all over the globe, there definitely were more males who were affected by the infection itself, and there was more cases of men who lost their lives to the infection rather than women. But if you look at the mental health affection, both in the general population as well as in the frontline workers or women who are remained at home. Mental health issues like anxiety, depression, post-traumatic stress disorders, PTSD, which can have lifelong impact, has definitely been on the rise. And again, I would say that this is something which we all need to sit up and take note of. Otherwise, uh, the mental health of a woman when it suffers, I, I will be very right in saying that the health of the entire family suffers. So we need to wake up and take notice of this and address the mental health situation of women more adequately. Now, a little focus on the female healthcare provider herself. So what protection does she need? She definitely needs more protection than the mask or the PPE kit. Now, if you look at the WHO figures, 70% of the healthcare workers around the world are women, although just 30% of them are in the leadership positions. Now, it's important to recognize that the pandemic has added new challenges to women in the healthcare sector.
Excuse me, madam.
Yes,
Just
sir.
can you sum up?
Yes, sir.
Can you sum up?
Yeah.
Time
This is my last slide anyways.
Okay, thank you.
Okay. So they form an important percentage of the healthcare workforce, and they are at increased risk of depression, anxiety, insomnia, and added stress. This I'm sharing a few suggested reading if anyone is interested in reading on the lines. So these are some very nice articles which I came across as I was researching this topic, which was given to me. So whoever's interested can look up these topics. So to conclude, healthcare workers who provide care to girls and women during the pandemic face a wide range of challenges in protecting their own selves, in protecting their patients, and in balancing their professional lives. It is anyways a challenge, but in these rapidly changing work environment women. So with that, I come to the end of my talk. So thank you once again for giving me this platform and allowing me to share my views on women's health. Thank you so much.
Thank you very much, madam. Actually, we hats off to all OBG people. They are doing a wonderful job because of aerosols and I would say a very risky situation in this COVID. We have talked about 160 million babies are coming up, 8 visits, and we are shortening it. Really a difficult situation, but we have to go for it. As you said that IMA should do something. We are having one, I think, webinar on 14th through IMA Pune. It is for common population about womanhood. So I request you, you can also be a part of that on 14th. That is same time 4 and above. Secondly, we can have some good platforms also for all the womanhood, I would say, programs, so that anyone can contact. As we have a helpline, we can have also a helpline for who are so is in distress or about mental health or maybe ANC or after pregnancy, maybe after delivery, they can contact if there are any problems. Sometimes it is very difficult for teleconsultation and personal consultation. They can contact freely with the panel of doctors from IMA. Thanks a lot for excellent presentation, and we can go for our next talk. Thanks a lot, madam. If any questions, we can get back to you. Thank you. So, with your kind permission, we can go for the next talk by Dr. Shailaja Mani. She would talk on artificial intelligence in medical field and bioethics. She is a professor, Department of Pediatric, Secretary of DPU Bioethical Committee. So I request Madam to take over her session. Being a wonderful session, she can go for artificial intelligence, a very important topic now coming up. Thank you. Please go on, ma'am.
Good evening, sir. Thanks a lot. At the outset, I would like to thank the organizers, particularly Kutte sir, Sanchiti sir, and all the team. And I will just rush through the my talk because it is too late now. So I will just highlight about what is artificial intelligence a little bit. सौरभ ये होत नहीं है. Okay, एक minute. Artificial intelligence in medical field and bioethics. This is a time travel where and how we. Sorry, एक minute. Just a minute. This is a time travel where and how it began and where it is going. See, this is a small clip which is very interesting. Please let me know if you are able to. Is it audible or what?
Yeah, we can see. 1 minute.
I think this is rotating.
Go ahead.
Ma'am, is it an audio clip?
Yeah, audio and video both.
Okay, we are not able to see the video.
Yeah. Just a second. Yeah. Here it is.
It's not a human mind.
Still the video is not visible, ma'am.
Video is not visible still?
No, ma'am.
I'm able to see it.
You can stop sharing and then open up the video and again do the screen share. You can open up the video.
Okay.
And then click on share screen option. Right, we can see it now.
Okay, fine.
I mean, look at this.
Is it audible?
Yes, ma'am.
Drucker's lab, I saw some fairly advanced robotics work. They deep sixed the data, but I gotta guess he was knocking on a very particular door.
Artificial intelligence.
Can you raise the voice, please?
Creating Ultron.
आवाज येत नाही.
This is the.
It's not a human mind. Look at it.
It's audible.
Duct tape? Hate to break it to you, bro. Already been invented. Hey. Ow, dude! Ow!
This is what I've been working at.
Hello, I am Baymax, your personal healthcare companion. I was alerted to the need for medical attention when you said, ow.
A robotic nurse.
On a scale of 1 to 10, how would you rate your pain?
Physical or emotional?
I will scan you now. Scan complete. You have a slight epidermal abrasion on your forearm. I suggest an antibacterial spray.
Whoa. What's in the spray specifically?
The primary ingredient is bacitracin.
It's a bummer. I'm actually allergic to that.
You are not allergic to bacitracin. You do have a mild allergy to peanuts.
Not bad.
Okay, General, I want to show you something here. This is a normal human DNA chain, okay? You, me, anybody, right? Watch this. The compositional elements of his DNA chain are the same as ours. There's simply more of them, tightly packed with infinite genetic knowledge, almost like this being was engineered. Tissue processing. Reconstruction complete. Remove the shield.
Like it.
It's gonna be okay. Stay with me, Dion. Whoa, the police are here now. Okay, you ready?
Micah, please take it slow. This will be very disorientating for a human.
My God,
Listen, do you have an angle grinder or something? Come on. Are you okay, Micah? Micah, do you have pain?
No, Chappie, I'm alive. I don't know what this means.
These are the few clips from Avengers, Big Hero 6, Fifth Element, and Chappie. Actually, a few years ago, no one would have believed that something like AI would change the way technology behaved so much. And now the development industry is looking at it like they have never looked at anything in the past. So this is AI is an emerging technology. World is adopting AI and changing at a lightning fast speed, covering every industry of a market. And AI has become now a necessity, and it can lead to numerous questions, confusions, ethical and bioethical concerns actually. So intelligent robots and artificial beings first appeared in ancient Greek mythology and antiquity. Aristotle's development of the syllogism and its use of deductive reasoning was a key moment in the mankind's quest to understand its intelligence. Steps were taken long back, while the roots are long and deep. The history of AI, that is artificial intelligence, as we think of it today, spans less than a century. AI is always there and all around us, from tracking our way, that is GPS, who drives us at home or whatever place we want to, entertaining games, various playing various softwares, helping with the diagnosis of the pathogen. Then we all know Alexa and our dear Siri. They are interacting and having personal assistance to many of us. Research has started long back, and still there is a long way to go. Actually, these are the various technologies which are helping or covering the AI: biological sciences, nanotechnology, cognitive sciences, material sciences, and of course IT. So tissue engineering products, gene therapy, drug combinations, then smart materials. The list is unending actually. So what is this AI? AI is a wide-ranging branch of computer science concerned with building smart machines, and it is capable of performing tasks which are typically require typical human intelligence. AI is an interdisciplinary science with multiple approaches. It is a mix of machine learning and deep learning. I will not go into the detail. So how AI works? There are 4 different approaches that have been defined in the field of AI, that is thinking humanly and rationally, acting humanly and rationally. So AI is there are 2 branches, AI in a virtual branch and AI in a actual branch. There is mathematical algorithm that improve the learning through experience. There are 3 types of algorithms: unsupervised, supervised, and reinforcement learning. I will not go into the detail because of lack of time. So in physical branch, there it includes physical objects, medical devices, sophisticated robots for the delivery, and delivery care robots or robots for the surgery, which all our previous eminent speakers have already mentioned about. So use of AI is very much required in robots to deliver the treatment, that is robotic surgery, and use of robots to monitor effectively. So increasing individual healthcare, why there is a need of AI actually? Why it is invented? Because there are a lot of issues like healthcare expenses are increased. There is larger geriatric population. There is imbalance between health workforce and patients, which is highlighted during the COVID pandemic all over the world actually. There is increasing global healthcare expenditure. There is shortage of nursing and medical staff and technical staff also. Number of vacancies are there. I will not go into the details. So AI is and it will be helpful to the medical practitioners effectively to achieve their task with minimum intervention. And there is a critical factor in meeting increasing patient demand. That is the need of AI actually. So there is machine learning in the healthcare, how it is used in the medical field. These are the few highlights. Disease identification, drug discovery and manufacturing, that is research, medical imaging, personalized medical treatment, how it is useful for the personal, at the personal level, smart health record keeping and disease prediction as well. So we'll go one by one in short. Correct diagnosis is a training for many years and of course experience, which is a time consuming process, and there is demand for experts which far exceeds the available supply. So doctors are always in the stress and strain, particularly during this pandemic. And machine learning is a very cheaper and more accessible kind of thing. So how machines learn the diagnosis? Actually, machine learns the algorithms, and these algorithms need a lot of concrete examples, maybe in thousands of images. And then they should be neatly digitalized. So at the start, at the beginning of the AI, there should be a proper imaging technique, proper technique of the proper digitalization and saving of the data, which is the need of AI actually. And for example, Google Photos in our mobile, how they identify the face and they ask us, is this the same person you are searching? So at the ground level, for example, images are taken, they are linked with the satellite and images are received in the medical institute, and this is the how we are doing, it can be worked. And here some doctor or team or some machine can do it, diagnosis can be made and treatment can be given at the ground level. Our prior speaker sir had already told it about telemedicine. This works in the same basis and it is useful for telemedicine as well. So actually there is very much important part of AI is at present also used in medical imaging technique. Funding and complete infrastructure for imaging services, that is what is needed. And there are, AI can change how there is a project called as Starlink project by Elon Musk. This is very well known project actually. The aim of this project is to provide global satellite internet connectivity, and AI will be able to control the interface and upload to the internet, reviewed by the doctors accordingly. So for example, photo booths will be there, which this MRI, CT scans can be done at that that booth, because these machines will be small, and health saving or life saving diagnosis can be made and treatment can be made at the earliest. So early and accurate investigations can be will be useful. ECGs and cardiac MRI images. Nowadays, HRCT is very much important in COVID. There are a number of situations actually. I will not go into the detail. This is the very easy example I will be telling. Actually, this is a diabetic retinopathy. This is the image of retina of a healthy person, and this is of a diseased person. So according to that, no diabetic, no DR, mild, moderate, severe, or proliferative can be diagnosed. So there are thousands of images. 130,000 such images are given to the AI, and according to that, they can diagnose. So any person who is working at the periphery also can assess and diagnose whether this is mild, moderate, severe, proliferative, and needs treatment immediately or what. So this is very good example of the machine learning, and you can see the accuracy. This is very high accuracy. So this is miraculous. So there are more advanced diagnostic technologies, which is combination of multiple data resources like CT, MRI, genomics, proteomics, patient data, and even handwritten files can be accessed. AI system will be used to highlight potentially malignant lesions, dangerous cardiac patterns, and interpretation will be within few seconds actually. There will be usefulness of AI in personalized treatment also. With the help of machine learning and system learning, there will be design of right treatment plan, particularly In case of malignancies, there will be radiosurgery. That means operation of the tumor will be useful at the accuracy without damaging other part, normal part of the brain. Another thing is, already this movie had told that improve gene editing. That is another technology which will be useful. Regarding drug development, we have never heard of remdesivir before COVID era. So how they develop, even vaccination development and all, they identify the molecule, discover. This is the routine, our technique, what we are doing at present. And this can speed up, AI can speed up the clinical trials, and they can find out the biomarkers and mutations and so on. So this will save the cost and time as well. So within this corona vaccine, COVID vaccine for the COVID had developed within a historically less time. So this technology is used in many of the vaccines actually. So storage of data, this is the huge and medico-legal ethical aspect. So this can be saved without occupying the physical space. So there are various benefits of the AI, that is increasing the efficacy, reducing the human risk, particularly COVID-19 pandemic. You have seen many videos, particularly from Japan and from India also, couple of videos that robots were going to the COVID-19 patients, and they were delivering the whatever medicines and food and all those. Particularly in radiology department, avoiding the exposure to dangerous radiation can be minimized. And there will be reduced risk of the human error, which can occur due to various stress and strain. And availability, like machines, like unlike humans, do not need to take rest, particularly during current pandemic and when everybody is overworked. List is unending. I will not go into the detail actually. There is rational decision maker. Actually, second opinion is many times is required, and it provides on-spot second opinion backed by tons of data. So it is not only second, there are many opinions and combined as a second opinion. But the rational decision might not be ethical. That is another problem with it. Actually, right program decisions can be taken if worked upon rationally. So preliminary data should be rationally fed. Humans, of course, are emotional animals, and emotions come along, particularly in, again, I'm giving COVID-19 because many of our near and dear ones are getting affected, and we have to take care of patients as well. So in AI, there is no distraction at all. Robots think logically, and their mood doesn't hamper the efficacy, and they are always productive at any time of the day. That is another benefit of it. So AI can assist physicians for clinical making decisions, replace human judgment, up-to-date medical information, 24/7 availability, and experience versus clinician can be helpful in that. Early diagnosis, prediction and outcome of the disease and management, increase patient safety, and huge cost saving will be there. There will be, it can extract the useful information from a large patient population. It assists making real-time interference for a health risk alert and health outcome prediction as well. Learning and self-correcting abilities to improve accuracy based on the feedback is there to some extent in the AI. So what is the role of AI in medical education? It is both preparing future physicians for a career integrating with AI and directly using AI technology in the education of medical fields, in the medical students. So medical education really needs reframing in upcoming few years actually. There is actually now focus on knowledge recall we have to shift this focus to interact with and manage AI and AI machines as well. So it requires diligent attention to ethical and clinical complexities, and use of AI with virtual patients in medical education is the reality. In many centers abroad, it is a reality. So technology is a useful servant, but it can be a dangerous master as well. So creating the future with AI must be careful. So what is the dark side of AI in the healthcare? Manipulations can change the behavior of AI. Actually, systems using tiny pieces of digital data is the reality. By changing a few pixels on a lung scan or MRI, nowadays CT lungs can change the diagnosis. It can diagnose what it is not actually there. So wrong diagnosis. Hackers might cause the patients to be misdiagnosed, and any hospital or anybody can actually manipulate if access is there, and it can lead to huge amount of billing, or insurance software can be manipulated, and their consequences will be there. So from AI joining hands to help, it can lead to a monster. So we have to keep seeking help. At that point of time, we may have to take the help to be saved from AI. This situation, I hope and pray, should not come at any time in the future also. So what are the new ethical challenges due to AI? There can be bias in the data. Certain demographics may not be involved in the data. Like for example, Madam had already highlighted pregnant women, elderly people, kids, breastfeeding women, like that. There can be bias in the algorithm, which we should ensure that there will be future impact in more positive way than the negative way. Ethicists, philosophers, there is need to involve, and not only get involved, but deeply involved in the development of technologies from the beginning. Decision making can be a challenge about the selection, testing, implementation of the robotic surgeries and all, evaluation of technologies for the use of healthcare. And we should recognize who is involved, which is very important, because there are many companies which are coming up, which are having an eye on only benefit and monetary benefit. So who is involved and how is involved? Identify and monitor how each group can and should take responsibility, and what they are doing, advances in ethical practices, whether they are following ethically or not. So these are the three main concerns actually where problems can arise. Medical ethics, ethical issues are involved in that, both whatever existing and maybe in the future, whatever potential. Monitoring is required by some authority or government agency, and even NGOs and medical professionals and organizations like IMA. They should ensure ensure preventative and precautionary safeguards. There is need to ensure that what is the future impact, which should be in the positive way than negative. Ethicists and philosophers, already we have discussed, should be involved. So this is the main core area, AI ethics. There are on one side ethical challenges, a diversity of stakeholders involvement. There is technical executives involved, computer and data scientists, engineers, academicians in technical disciplines. On the other side, bioethicists, lawyers, psychologists, liberal academicians, public and civic advocates. So they should come together, join hand in hand, so that AI can be used in an ethical way. So what are the ethical challenges? Actually, there is no human replication. Machines are rational, but they don't possess emotions and moral values. They don't know what is ethical and what is legal and what is not ethical. There is no judgment making skills. They are in unfamiliar situations. They can perform incorrectly, erratically, or they can even break down in this unfamiliar or unfed situations where data of that situation is not fed, particularly COVID. We all humans are adopting and we are trying to find out the way from this situation, but AI cannot do that. There is no sense of belongingness or togetherness. There is no human touch, and AI fails to distinguish between a hardworking individual and an inefficient individual as well. So it can create a problem. There is no improvement with experience. This is very important in medical field, because experience, skills are the things which evolve with the practice and many years. But there is no improvement with experience in case of AI. So they can perform the same function again if no different command is given to them. So it needs improvement. Machines cannot be creative on their own. I am saying actually only do what is taught to them and what is commanded. So they can't match the power of the human brain actually. Humans are sensitive and intellectuals and very creative too. They can generate the ideas, they can think out of the box, they can see, hear, feel what machines cannot do. They can think and they can be guided by the feelings, what we can say sixth sense. One of our prior speaker had told that they have told to test the COVID. So sixth sense or whatever experience, it is lacking completely in case of machines. There is intuitive ability in the human brain which cannot be replicated in the AI. So going ahead, we already discussed this. I will go ahead. So data sourcing, product development, and clinical development. These are the three domains. This is busy, very busy slide. I will not go into the detail. I just want to highlight these are the three broad areas where AI can be useful. So is it a threat to medical field? Actually, at professional ethics, generally it deals with various parameters like behavior of the professional, impact of their services on the patients and public. But in AI, it is a third additional layer of complexity and it must be addressed. That is behavior of the machines. So behavior of the machines regarding safety and efficacy is very important. How and what matter, what machines are doing is what matters. It's being programmed and it is, we have already seen, it lacks in emotion. It might show impacts on the ethical decisions, rational decisions, and other questions. And human oversight is, of course, needed on that. So what to do about the ethical issues? There are various common pitfalls between the decision of AI and healthcare professionals, and we always have to have balance between working with the AI and ethics. So there is need for regulation and laws and incremental progresses. There should be a framework which comprises of 5 domains, that is participant privacy, risk and benefit, access and usability, data management and privacy, ethical principles, and these are the 5 domains which should be intersecting. We should have intersecting relationships with each other. So what are the ethical principles involved in that? Since we are talking about ethics, respect for the person. So data management can be an important part. Beneficence, access and usability, justice, privacy, risk and benefit. These are the main domains which we should address about. Regarding weighing cost and benefit, financial cost, initial cost will be huge, but I don't know whether it will be at present in a countries like developing countries like India, whether it can be justified in the near future or future. Yes, it will be. Privacy and ethical cost is huge. Reputational cost against and aggressive marketing by many companies can lead to unrealistic expectations, anxiety, skepticism, and related problems. There is ethical dilemma as well. Who takes the responsibility for crucial decisions, whether the doctor, AI the software, or the software manufacturer? Who owns the data? Patient, hospital, or the software manufacturer? Can they sell this data to other companies like insurance companies or any advertised companies? Or it can be hacked, like whatever happened with the Chinese softwares now. Which company will have the biggest impact on AI in healthcare? There are so many dark horses: Amazon, Google, Microsoft, IBM, and many are upcoming. So human and AI cannot be put at the equal rank. Both exceptionally are good in their same field and may lack in other field. Both together can do the miracles. Being mindful for the new health technologies is very important, and it can fill the gap between what is known and what is unknown. So infrastructure is needed. Selecting and implementing technologies in the digital health ecosystem is what it is required. New technologies are there. They definitely are adding potential benefits to the mankind actually, but may exacerbate the health disparities among most vulnerable people. So what are the potential challenges? Initial developmental cost, integration of issues like ethical issues or fear of replacing humans, data privacy security, data exchange, then state and federal regulations. These are the very important issues. And industry challenges are very much. I will not go into the detail because of lack of time. So we need to have some collaboration between medical and technical institutions to do the research in that. And we have to stop working in solos, remove the firewall of clinical load, and government funding should be there for AI. And we are very happy that in last budget, they have done some arrangements for the AI, though it is peanut, it is at least started. There is, we should bother about scientific mafia or scientist mafia, what it is called as. Current status of record, we are wasting huge amount of data which can be useful for the mankind, particularly in the COVID. We are having so many complications in the children which is not in the reported actually, and we all should report it. And we are in the process. Of course, there is one conference upcoming in that will many of us will present the cases which will be beneficial. So it can be done in within seconds actually. So laboratories, clinics need collaboration to accelerate the implementation of electronic health record, and real-time data should be captured, and institutions should promote their transformation into intelligible processes. New scientific and clinical findings will be there. Electronic medical and health record will be useful. So these are the couple of suggestions. Anticipate potential ethical pitfalls, and we have to identify various possible solutions, and policy recommendation should be there. And we all as physicians should adopt AI as far as possible and as early as possible. Adoption of policy on AI in the healthcare should be there. So to conclude, we must embrace the new technology, and which is changing the way of living. Actually, it is important to have a look at the positive outcome for welfare of the society and eventually to the humanity. AI must not take for granted. It can have negative impacts too. So be ready to face consequences. Employment, privacy, very existence of ethics and humanity can be questionable. But people like Eric De Souza, Russell De Souza, many stalwarts like our team members, eminent speakers today, they will have the job of it. And we have to forward this baton to our future generation too. This is a small video. I think I will skip it.
Madam,
so this is the last slide. AI may fly as high as kite, yet a thread to be tied and kept with us to put a check on it. A big thank you to all. Stay safe, stay happy. Thanks a lot. Thank you, sir.
Thank you, Madam, for a very excellent and lucid presentation of artificial intelligence. It can be a boon also and a curse also. Whatever we have to take the positivity. Technocrats, I do remember, just in short, I tell you, we are having one smart stove which is detecting cancer. So one of our, GPs or practitioners, they just have a check and they send it to Bharati Medical College and they go for matching. And then if you find it is cancerous, the patient is immediately taken for further management and assessment. So I just conclude and thank a lot for, I would say, very nice presentation. And we'll go for next lecture by Dr. Motilal Taide. Thank you, ma'am.
Thank you, sir. Thank you all.
Dr. Motilal Taide is Assistant Professor in Physiology at PMC, that is Loni, Secretary for Bioethical Program. Sir will speak on challenges of doctors in COVID-19 pandemic. It is a challenging topic and the last topic. So I request sir to take over. Please continue, sir.
Thank you, sir.
Taide, sir.
Yes, sir. Thank you, sir. Can you hear me? Yes. Very good evening, all of you. This is today's my last session on the base. The organizer given me a topic, the challenges of doctors in this COVID-19 pandemics. First, I thanks to the all great personalities, panelists, members that are involved in this today's Ethicon. I thank organizers for organizing such a wonderful fest on different topics shared by different panelists in different issues based on single platform ethics. When we see as ethics in this particular situation, in this COVID-19 situation, what are the challenges that are put in front of us as a practitioners, as an educationist, as a researchers, and as a humanist? I just here share my PPT. The COVID-19 pandemic has prompted dramatic changes in the clinical care environment. The COVID-19 epidemic is unique because of its scale, its speed of spread, what we are today observing in Maharashtra, in different cities like Pune, Mumbai, Vidarbha, the lack of pre-existing scientific data and importance of media coverage, because this is the disease or this is the situation, health situation that media has given, either electronic media, print media, every media, even social media has given a huge publicity. And this is unique in all scale, on its scale, spread, data-wise, and media coverage. However, the resilience of health systems in response to COVID-19 is open to question. When we see the health system resilience can be defined as the capacity of our healthcare professionals, our institutions, and populations to prepare for such situation and effectively respond to such crisis to maintain a core functioning with crisis seat and informed by lessons learned during this crisis and to recognize if the condition required for it. During such epidemics, a coordinated and multidisciplinary management between specialists in infectious diseases, ICU doctors, and infection prevention and control, and also the hospital management is of paramount importance to provide optimal care. Now, healthcare workers are at the forefront of this epidemic's response, and they must be supported by our community, regulatory authorities, and government. Many health structures will face an increasing number of patients with COVID and have to anticipate the consequences, including the need for more beds, trained healthcare professionals, ventilators, and medicine. Like today, we are facing the shortage of remdesivir as well as oxygen in different parts of Maharashtra. But we are observing the news channels just highlighting these issues repeatedly. In order to face this outbreak, hospitals have to anticipate the consequences of COVID-19 on all the departments, including indirect impact on non-infected patients. That is very important to ensure the commitment of hospital management staff and health authorities to encourage effective leadership, to involve and care for all healthcare workers, and to organize communication with the wider public. That is very important. And we, as the doctors, as leaders, and it is a great responsibility to us to communicate with our public, with our community in such crisis. When we see the ethical principles guidelines, clinical care during this pandemic, basically the patients are divided into two broad categories in today's era. That is COVID patient and non-COVID patient. We all are focusing toward the COVID patient, but what for non-COVID patients? What is our responsibility toward them? How we should deal with the non-COVID patients? That time, different issues are come into focus. The most prime issue is patient priority adjustments. During the COVID-19 pandemic, there has been a rapid shift from prioritizing the outcomes of individual patients to optimizing the health of the community. Consequently, healthcare systems have adjusted clinical operations to minimize spread and morbidity associated with COVID-19 and to preserve their ability to provide acute care in the context of increased demand. That is one of the most important issues as the patient priority adjustment in front of us as doctors. The second important issue is alterations in available treatment options. When we see the previously available treatment options may be altered or restricted by the institution or regulatory groups, or maybe the lack of sufficient data that prove them, or the clinical trials that may prove them. For example, there is observed a number of times alteration in available treatment that the doctor has planned with his patients before such situations. For example, a primary surgical treatment for a suspected malignancy may not be possible due to the restriction on operating room usage. Such like issues today we are facing with our patients, with our regular OPDs, with our regular operatives, with our regular patient management, especially with the non-COVID patients. Vice versa for the COVID patients, the treatment alterations are now somewhat stabilized. But however, there is a question of individual patient management and plan our own treatment plan for it on ethical grounds. The second, institutional policies related to the morbidity resource allocation may appear to devalue an individual patient's preference in deference to the common good, an approach that may conflict with the standard approach to shared decision making, and that is there is limitation to us in this situation. Third important issue is restrictions on clinical care. The restrictions on clinical care may be ethically difficult for healthcare professionals and patients and may cause patients and physicians to feel a loss of control. The fourth is ethical obligations on doctors. Physicians are professionally obligated to be willing to take on some risk to themselves during patient care. However, this obligation is not unlimited. Clinical practices, therefore, may not require or expect physicians to provide care without adequate personal protective equipments. Now, this decision is highly individualized and should balance physicians' desire to provide care with the likelihood of subsequent personal morbidity, risk of subsequent transmission of COVID to our close contacts, and implications for physicians' ability to care for the future patients. That is the most important issue that is arise during these situations. Very importantly, the clinical practices should not exert social or economical pressure on physicians to provide clinical care without adequate personal protective devices. When we see the general principles for allocations of scarce healthcare resources during this COVID-19 pandemic, healthcare systems are under pressure to develop and implement crisis standards for care. That is most important. That outline procedures for disaster response, including allocation of resources for which demand is expected to exceed supply. Although much attention has been paid to the possibility of a shortage of medical ventilators for critically ill patients, the examples of scarce resources also include medications for supportive care, intensive care units, intensive care unit beds, operating room timing, and healthcare professionals able to manage a potential surge in demand for acute care. And nowadays, this is a major issue of the management of acute care. The healthcare system should ensure that protocols allow for uniform applications and do not force physicians to make bedside decisions about resource allocation on a case-by-case basis. The palliative care is another issue. The palliative care is specialized medical care for patients with serious illness, focus on providing relief from symptoms and stress of any serious illness, with the goal of improving quality of life for the both patient and family, and we are lacking at here. During COVID-19 pandemic, this area is strongly impacted. Next area is the communication scenarios and skills, particularly critical to COVID-19 related conservations include delivering bad news and advanced care planning. This is another area that is today more hampered. Now, when we see the ethics and COVID-19 situation handling and our challenges from the resource allocation and priority setting, physical distancing, public health surveillance, healthcare workers' rights and obligations to conduct clinical trials, the COVID-19 pandemic presents serious ethical challenges. These in turn are complicated by the diverse healthcare systems and unique cultural and socio-economic context of the different countries. When we see that consequently, there is a great need for guidance to ensure ethical conduct of research, decision making in clinical care, and public health policy making at every level, at world level. When we see the ethical values to justify the priorities for critically ill patients supported, nowadays we are facing this in today's era, and factors that should be theoretically considered for decision to admit or not the patient in ICU. Today, this is a question either to admit the patient or not due to the bed shortage in Maharashtra. Now, today, this is the issue to admit the patient or not. Is he symptomatic or not? If he's asymptomatic, can I put him at home? These are the different issues. These are different issues that are facing in today's practices. To overcome the COVID-19 pandemic, in many places throughout the world, new resources are developed in a short period of time, dramatically increasing the number of ICU beds, allowing admission of a huge number of critically ill patients, though there is short. In such situation, every option is associated with its own strength and weakness. In such crisis, there are ingredients liable to shake up our ethical principles, sharpens our ethical dilemmas, and lead to situations of sufferings. Whereas to put setting priorities in ICU, family care of the patients, healthcare workers' psychological issues, economy impact, heavy demand of healthcare resources, doctors and paramedicals, patient autonomy, beneficence of patients, non-malage, justice, patient confidentiality, privacy, and patient consent. All these issues should be taken care with this during such situations. Now, when we come towards ethical dilemmas are situations in which there is a difficult choice to be made between two more options. The ethical dilemma that is defined by the Kidder as right versus right, or at the heart of our toughest choices. It's very challenging to choose between two right options, and this we are facing today. In COVID period, we're experiencing this. When we analyze the ethical dilemmas in this situation can be divided into different forms in front of us. The first ethical dilemma for healthcare professionals to us is patient priority and resources allocation. That is the most important to us. Second ethical dilemma, designation of hospitals as COVID and non-COVID. How to manage the inflow of patient, how to manage bed shortage, what decision I should take for this inflow of patients and bed shortage. Lack of emergency management systems, ventilators, oxygen, emergency drugs, patient priority issues, resources concerned with medicine and other management. And last, very important, treatment cost of my patients. The third ethical dilemma, that is contradiction at ICUs, either how to prioritize to my patients and manage needs. Fourth ethical dilemma, total separation of patient from the family and well-wishers that is happening in today's COVID pandemics. These ethical dilemmas have led to the defining breach of medical ethics practices resulting from burden of heavy patient inflow. In this second wave, we are facing more issues than prior due to the speed of outbreaks, especially in our state. The question is how to crack these decision-making dilemmas as a doctor. For that, we have to remove our emotions. Emotions are an essential part of all decisions, but do not let them to get the upper hand. Take time to think. Flexibility is our key. You will be wrong sometimes, but you have to take decision. Stop being cruel. That is very important. Commit and follow through. Build your muscle and help yourself. This is a simple key to resolve the ethical dilemmas and different situations that may come in front of us as ethical grounds. The doctor's ethical challenges during COVID period is basically the ethical dilemma, decision-making dilemma during the patient management, self-protection, family protection, economy, regulatory pressures, community pressures, and very importantly, proven leadership during such situations. In conclusion, the systemic approach for prevention, control, treatment, and rehabilitation for patients during COVID pandemic will be help in better management of this disease and its epidemiology. The major burden of this pandemic is that healthcare providers are faced with huge resources. That is the major ethical issues we are facing during this due to the limited resources with
Hello. We can't hear you, sir.
the other burden that is increasing day by day. The worldwide large number of patients with COVID are seen dying in emergency rooms or intensive care units.
Hello.
In this era of rapid changes and social distancing and financial mental health, we as doctors don't limit your. However, the issues noted during this pandemic situation have been associated with lack of accountability, issues in resource allocation, and loss of trustworthy every major as well as minor decision, ethical thinking and practices. Managing ethical dilemmas with situations will be challenging. With this, I conclude this session with a quote: ethics is knowing the difference between what you have a right to do and what is right to do. With this, I conclude this fest. Thank you. Thank you to all. Thank you, IMA, Shirdi, and Maimar Medical College to give me an opportunity to talk about this issue. I thank all the dignitaries, great personalities that shared views as a panelist. And with this, I try to highlight this closing issue. Thank you, sir. Thank you, sir.
Thank you very much, sir, or I would say excellent presentation regarding the condition in COVID-19. The cases need, I would say, a lot of care, but sometimes in ambulance itself, there is death, and sometimes a lot of things happen also. There is violence also. So ethically, 100% we are right. Whatever our doctors are doing their best in this COVID epidemic, but I think people should realize and they should support also whatever is going on, and they also know that our doctors are the example for the world. I would say that they are risking their lives also. So many deaths have also occurred. We pay all the tribute. I think more than 800 doctors led their life as martyrs, corona martyrs, and it was very unfortunate. So in conclusive remark, I would say that whatever the things are happening now, we are short of ventilators, short of remdesivir injections. There is huge queue, and I hope the government is looking into all these things, and ethically all things should go right. And this session was really important, I would say. I had joined because of Sai Baba's blessings, and it was, I would say, really a great privilege and honor to be as a coordinator for this session. So I thank all the faculties, all the members and delegates who have joined this, I would say, very useful and informative session. And lastly, I thank all Mr. Dipen of DigiShield. So also the technical people who are giving us moral and technical support also. In future also, we can have such great sessions. Lastly, I request Dr. Kute, our organizing chairman, to take over and conclude giving remarks. And if anyone wishes to speak also, is most welcome. I request Dr. Kute sir to take over. Thanks a lot.
Thank you, Rajan. Is it audible?
Sir, we can't hear you properly.
Yeah, good evening. Is it audible now?
Yeah, I can hear you.
Hello,
I hope.
Rajan. Yeah.
Your voice is
Today's webinar on bioethics, hosted by IMA Shirdi branch. This is consecutive 8th year of IMA Shirdi to conduct national or international conference. Today's webinar was in association with International Chair of Bioethics, Maimar Medical College, Devaluation Medical College, Pravara Institute of Medical Sciences, Deems University, IMA, Junior Doctors Network, Medical Student Network, and it was highly successful. All the faculties, speakers, and their presentation, it was par excellence. Dr. Eric De Souza sir, Dr. Shivkumar Utture, Ravi Vankadkar sir, Sushma Sharma madam, Shailaja Mane madam, Futility sir, all these learned speakers and their topics, it was really a feast, academic feast to listen to their presentations. And definitely all the students, all the doctors, they must have benefited by today's webinar. And this association of series of Bioethicon lectures will be conducting in future also. I'm thankful to all the speakers. There must be many more lacunae, communication lacunae. So we regret for that. And thank you very much, Rajan, for your important role as coordinator of today's webinar. Dr. Russell De Souza, he has given a consent to conduct such sort of international program of bioethics, but there is a 4.5 hours time duration between India and Australia. Suppose in the morning only he told me that go ahead, I am with you. Dr. Ved Prakash Mishra, he has forwarded today's webinar, and all the stalwarts, they were present. And thank you very much. Thank you very much, sir. Rajan, please continue.
Yeah. So
Rajan, please continue.
Yeah. Thank you, sir.
Thank you, Kute sir. Thank you, Rajan. Excellent program. Keep on doing it. Thank you. Good night.
Okay, good night, sir.
Yes, sir.
Lastly, I would like to thank Dr. Ravi, sir, Dr. Ved Prakash Mishra, sir, our stalwart, inspiration, Dr. Eric De Souza, sir, Kannar, sir. We'll always be grateful for you for this academic feast. Then Dr. Sushma Sharma, madam, Dr. Shivkumar Utture, our president, sir, Dr. Shailaja Mane, madam, and Dr. Motilal Taide, sir. This was really excellent academic feast, and I hope everyone enjoyed. Thanks a lot. And namaste. Goodbye. Good night.
Thank you so much.